You're all set. It just the presentation.
Which one? Tyler? Which one? Good morning. Welcome everyone to our 5th Annual Global Health Symposium. I'm so happy to have all of you here with us today. My name is Dana Park. I'm an investigator at the Global Health Initiative here at Henry Ford Health System, as well as the chair of the planning committee for the symposium. Let me first ask, has anyone in the audience been here all 5 years? My colleagues, of course, but wonderful. Thanks, guys. Anyone here for 4 years? Wonderful. We have a few more hands in the audience. Great. Thank you so much for being here along this journey. And of course, thanks to all of you, new and returning, for being here today. These 5 years have been quite a whirlwind. From our first symposium back in 2014, looking at building on the power of partnerships, to 2015, focusing on sustainable solutions, to learning about strengthening clinical and research capacity in 2016, to last year, looking at the spectrum from implementation to impact. Building on these cumulative lessons that we've learned over the years, we chose to focus the theme of our 5th Annual Symposium on the resilient city and how we can prepare for a healthy future. Over the years, we've hosted speakers from 13 countries, and we're very grateful to today's speakers from Mexico and Thailand for traveling so far to be here with us today. Our audience has also presented over 230 abstracts on global and local health research and projects. I can't wait to see the exciting abstracts being presented today. Kudos to all of you for your very important work. Here at the Global Health Initiative, our definition of global health includes local health for underserved populations, and we have emphasized the synergy in every single panel, every single year. Today's event will be no different. I'm so excited for today's speakers to highlight the many successes towards resilience right here in the city of Detroit, as well as discovering new opportunities for us to learn from our partners all over the world. The world's facing many challenges right now. 2 factors I'm personally keeping an eye on are rapid urbanization and climate change. So for example, in Africa, by year 2030, over 50% of the population will be living in cities. However, many of these cities lack infrastructure to provide equitable access to health. Additionally, over 80% of Africa's capital cities lie on the coastline, increasing their vulnerability to climate change. So I hope that by listening to today's great lineup of speakers, you all will better understand some of the social determinants that correlate to health outcomes, and that you prioritize interdisciplinary approaches and partnerships as you develop health interventions and solutions, as we all work to achieve a more resilient, healthy, and equitable world. Before we launch into our exciting day ahead, I have a few housekeeping reminders. If you haven't checked in yet at the registration table, please make sure you sign in. Restrooms are right down the hall, right around the corner to our right, if you go out towards the lobby. And then there's additional bathrooms to the left across from the cafeteria. We would like to acknowledge our gold sponsor, Allergan, and our silver sponsor, AKT Peerless Environmental. We are so grateful for their support in hosting today's event. We also would like to thank our supporters, Global Goods Partners, and Henry Ford Hospital Administration. Most of the program will be right here in this room in Berkey Auditorium. However, our lunch and poster session will be back out in the atrium. And then also, after you've viewed the posters, please vote for your top 3 choices. If you look inside the back cover of your program book, there's the QR link and website for you to go in and vote. And we'll be announcing the top 3 posters via email after the symposium. Finally, I hope you all received an evaluation sheet. We really do appreciate your feedback. If you can turn those forms in at the end of the day back at the registration desk. And then also, please join the conversation online using our hashtag GHSDetroit2018. However, please turn off the sound on all your cell phones so our speakers aren't interrupted. So now I am thrilled to officially launch our 5-year celebration of the Global Health Symposium by introducing our keynote speaker. Dr. Amy Schultz is Executive Director of Population Health for Henry Ford Allegiance Health and Jackson Health Network. She's responsible for the oversight of planning, development, and operational implementation of community and clinical network models that advance the triple aim. This includes providing leadership support for Jackson Health Network's clinical integration program, value-based contracting strategy and care management model, and Henry Ford Allegiance Health's community health infrastructure and clinical community linkage development. She also provides part-time support as medical director for Jackson County Health Department. And she's been involved in the leadership of clinical preventive service improvement and community-based health improvement in Michigan for quite some time. With that, I would love to welcome our keynote speaker. Please join me in greeting Dr. Amy Schultz.
Thank you, Dana. I'm really excited to be here and feel a little bit out of my league with all of the great international speakers we have and the topics and all the learnings we're going to have from around the world. But I am very excited to share with you some of the work we've been doing in Jackson, Michigan, around the vitality of our community locally. So I'm just going to talk a little bit about how we're approaching issues as a community, both the health of our population as well as the intertwined social determinants that affect those outcomes that are experienced by an individual, not as silos of different sectors, but as a whole. And I'll be talking about it keeping in mind the role that our health system has played in that work over the years. So for those of you not familiar, Henry Ford Allegiance Health joined the Henry Ford Health System about 2.5 years ago. We're a 475-bed facility in Jackson, Michigan, which is about an hour and a half from here, west of Ann Arbor. And we have a fully integrated system of care and lots of ancillary services, as well as a really keen focus on health improvement from a population health perspective, and I'll talk a little bit more about that. But Jackson, this is not our current county health rankings, but kind of an example. I'll show more how we've changed over the years. But Jackson is a pretty underserved area, and we have kind of a mix of rural and urban settings, so we have an inner city dynamic for sure, and then a lot of our population is in much more rural areas. So as we're working with the population, we're working on both perspectives there. And you can see that some of our challenges in Jackson have focused on the health behaviors and our social and economic factors pretty significantly, while our clinical care rate's pretty high. So just to give you some historical perspective on how the health system became involved in population health improvement, in the year 1999, our system owned a local health plan, and we were rolling rate increases out to local employers of about 40%, which is an unsustainable increase for employers to be able to absorb. So what we were hearing from the employers is, well, we're either going to have to decrease coverage or pass costs on to our employees, which then is going to lead to more undercoverage, poorer access to care, and a sicker population, which then just feeds into the high cost of care in our community. And our board at the time recognized that that's a really unsustainable model. That's a downward spiral. And where we really want to be focusing is how do we improve the health of the community so that we can reverse that cycle and create a more vital community that doesn't have those costs and issues to deal with. So as a health system, one of our board members said, why do we want to be a health maintenance organization? As a health plan, we want to be a health improvement organization. And that really spawned the concept of us as taking on a leadership role in supporting our community in better health, not just in sickness. And the model that we kind of have followed, and this is taken from some of Neil Halfin's work and Tony Rogers when he was at the Centers for Medicare and Medicaid, is the 1.0, 2.0, 3.0 model of healthcare. So in 1.0, we do a really good job of taking care of sick folks if they need it. It's very important. We have to provide really quality care, make sure we're avoiding complications when someone is sick and needs that type of care, taking care of the individual. As we move to the 2.0 population, we are looking at being accountable for a population of patients that are attributed to doctors in our network. And we're looking at their whole experience of care and how we're coordinating that across different healthcare providers. In the 3.0 model, we're looking at the population holistically, so in our case, our whole community, and how they're experiencing care, not just through the medical system, but through all of the interactions that they have at work, at home, at school, in their neighborhoods. And we're integrating services and approaches to best meet the needs of that population holistically. And so that's really been the framework that has guided us from a health system perspective at looking at transforming. It's not either or. We have to do one, we have to do two really well, but also to be able to do three really well. And I'm going to talk about some of the other tenets that have kind of driven us as we've progressed on this work, and then start to tell a little bit more about our story. So one of the key realizations that allowed us to be more effective in supporting this work as a health system was the realization that healthcare alone only impacts about 10 to 20% of health outcomes through what we do in a medical setting, and that the rest of it is driven by other factors such as our health behaviors, the social and economic factors, and the physical environment. And that if we're going to truly impact population health and those outcomes, that we can't do it alone as a health system, that we really need to build a community approach to this and create the partnerships that would allow us to be successful in impacting those outcomes. So this framework, the recognition of this framework, and the adoption of it even at the leadership and governance levels within our organization has been critical to, as a health system, being effective in helping our community. The other piece that's been really important for us and our partners as we've progressed on this journey is the understanding of how complex the system is. If you're trying to address a complex social issue like health outcomes or any of the others that you all work on, we know that it's not so simple that you put a program into place and you see a direct line to your desired outcome and the impact is there. This is the world that we live in, and this is the world that individuals experience. Anything we try to change in the system is going to react to maintain the status quo. So we really have to look at an approach that says, what are the multiple overlapping things that we're doing? How are we anticipating the unintended consequences and working together to address things from a systems change perspective? So you'll hear me talk about that over and over again. From a systems change perspective, is changing the conditions that people are experiencing, the policies, the infrastructure and systems that we've built, so that it doesn't just revert back to status quo when we try to implement a change. The other piece that I'll mention and again later is the role of the individual in helping us understand how they're experiencing this system. So as we started as a health system to look at, well, how do you approach population health? Certainly we aren't necessarily the experts. My background is in preventive medicine and public health, so as I joined the team within the health system, it was pretty progressive at the time for a preventive medicine physician to be employed by a health system. But we really started looking at, who are the partners that we need and how do we start this work as a community together. And so what we did was, and this is back in 2005, so the health system didn't have to do a community health assessment per the IRS at that time. But that was what we needed as a community to start getting everybody together and identifying the common issues that people were experiencing and being able to collectively look at what the priority issues were and identify what resources were being applied to them and where the gaps were, where the lack of coordination was, and how we could improve upon that. So what we did was created a coordinating council of community partners, so including our school systems, employers, our federally qualified health center, our social service agencies, to come together and embark on this journey together. And one of the key things when we started doing this was that the health system committed that we would provide the backbone infrastructure to support that. So what we didn't want to do was go to our partners and say, hey guys, let's start working on this without a commitment to sustainability of that infrastructure, because we know everybody has their day jobs and everybody's already working on really important work within their agencies. To come together collectively like this, we have to be able to provide a support system that's going to allow that work to flourish and not pile on, so to speak, all of the administration coordination of that. So we committed as a health system to do that, and at the time aligned some of our community benefit funding from, we have the long list of agencies that we provided a few $1,000s to every year that wasn't making a difference to them, and reinvested it in some backbone support and staff to make sure that the initiative that we were engaging in together would have longevity. So the key things that happened after we began this work together, as a community, we didn't necessarily have the trust that you would have between the different types of agencies and sectors to do this. So we were working to build that throughout this whole process. I talk about this now, 10, 15 years later, and I always tend to minimize that piece of it, but it really is that kind of work in a community where you have to build the relationships. And one of our key wins was, as we embarked on this work together, we were able to go to the county government and show them that we're already working on this as a collective. We have 40 different agencies who are engaged, and that they don't need a separate strategic plan around health improvement when they have been a key player in this work, and showing them the work that we're doing in the resulting plans. And the same thing with the United Way. And so we were able to get some key players who were really supportive and said, hey, this is our strategic plan around health for our community. That was created by the collaboration of these many groups. And the focus areas that those groups have identified and the action plans that those groups have created are the plan for our community. And that allowed us then to start bridging out more and engaging more of the smaller agencies or the sectors that might have been more isolated, because they saw that these agencies in our community were endorsing this work that we were doing. And some of our funders, as far back as 2007, were aligning their funding with this, saying, hey, if the community is going to come together and create a plan, then we want to see how your work is aligning with these collective plans. The collective impact model is a tool that we use to describe how we do our work. It isn't something we modeled our work after. It is actually something that came out in 2011 that have given us words to talk about the way that we organically developed or failed our way forward to the model that we currently use. So what we have within this model is the Coordinating Council, which creates that common agenda across the agencies that are saying we're not each working towards our individual agendas, but together we have identified common goals for our community, and we see how our agencies each play a role in that. Then we have action teams that are working specifically to create strategies that are going to help us achieve that goal. We have partner organizations who are really the ones with the boots on the ground who are doing the work that are helping us collectively achieve those outcomes. And then of course we have our community members who we're engaging, and I'll talk a little bit more about some of the approaches that we're taking to not treat them as recipients of the work that we're doing, but as champions of that work. And then along the side, you'll see that green arrow going down, and that is the backbone infrastructure. So that is where we're saying it's really important that we have a way to connect all this work to make sure that we have continuous communication between the pieces that are working at various levels, that our activities are mutually reinforcing, that we have shared measurement, and that implementation is achieving the outcomes that we desire. So some of the implications of creating that structure in our community have been really the culture of collaboration, which has really changed. And again, at this point, we kind of take it for granted that an agency is not going to start a program that exists somewhere else, go out and try to get individual funding for that program, and ignore kind of what are the other community agencies doing and how does that align. So we really had a change in the culture of our community as it relates to the way we work together. One of the examples of this is our public health integration. So Dana mentioned my role at the health department, which came about several years ago and is a shared position. We also have a shared health officer position. So the health officer of the health department is also the health officer within the health system. And so that common role of recognizing we're serving the same community, our population is the same, so we really don't need to have separate infrastructure to be focused on how we are improving those outcomes. We're doing that together, and so we've aligned those resources. Another piece that has come out of that has been the work that we've done with our physician population. So we really leveraged some of the same techniques and approaches we took with aligning our community stakeholders to our physician population when we created our clinically integrated network. So bringing those physicians together, both employed and independent, to create the measurements that they wanted to be accountable for as to how it related to how they were improving the population health and the outcomes, and then aligning the payment systems to better support those types of outcomes in our physician population. So I'll talk again about how important our clinically integrated network is in the work that we're doing, because we're aligning what we're doing on the community side with what we're doing on the clinical side in that way. We're also integrating the use of our electronic health records. So while our physicians within our clinically integrated network are all using that so that we have a shared registry, we also have our health department on the same records, so that as they're doing their work within STDs or immunizations, that we're using the same record, and that creates the opportunity for closed loop referrals within those systems. And we have expanded on that closed loop referral concept, and I'll talk about that a little bit more. The other implication of this work and the trust that we created in the community is that we started to replicate this model. So we now have an education, cradle to career education network that is focused on educational attainment, that uses that same coordinating council model with action teams with a backbone infrastructure. And the latest network that we've stood up is the Financial Stability Network, which is focused on, which is focused on poverty reduction. And so while we've developed these networks within our community, we've obviously started to recognize that doing network-based work, where you're decentralizing the power and having those who have the most expertise and are working with the target populations most closely, that there's learnings that we all need to apply to that work. So it's not so different because we're doing network-based work in health than it is whether you're doing it on education, whether you're doing it on poverty reduction. So while we have content area focuses, we have some real standard work that we've created to support the network broadly. We have a network manager who looks at the processes that we use, the information sharing. We've created an information sharing network where all of our partners can log in and see the materials, the meetings, the strategies that others are working on. We've also created a collaborative council that kind of looks at those cross-network opportunities and how we're doing the work as much as what that content area is, so that we can make sure that we're really focused on the common values that we need to be as a shared network. I'm going to talk next a little bit about those values. Oops. No, that's where I want to be. So the collaborative network, as I mentioned, recognize the commonalities of network-based complex system work and has created infrastructure. And I'm going to talk specifically about one of the values around authentic engagement. But first, I just want to read you the vision of the collaborative network, because it is kind of, when I talk to other folks, sometimes they feel it is a very nebulous concept, and I thought this might be a little helpful. But the vision is, there exists a sustainable collaborative network in Jackson County that is united by common values and committed to efficiently serving the community through lasting systems change. So that's the broad umbrella of how we view the work that we're doing collectively as a network. And then the common values that we identify are equity, authentic engagement, and continuous learning, to make sure that we're applying that as we're engaging in this, in changing the conditions that our populations are experiencing. And the authentic engagement is really focusing on that transformation from engaging our population as either recipients of services or token representatives, where we do focus groups with the population. We're saying, well, we're listening to you because we collected information from you, to really moving to that champion stage where there's ownership within the population of a change that they want to see happen, and we're supporting that. So that's a really important premise and foundation of the work that we do as a network. Kind of big picture overview of where the network is now. We have switched from doing a community health assessment to doing a collaborative community assessment. So that means we're no longer asking just questions about, did you have your mammogram? Right? We're asking about the conditions that people live in and experience, their barriers to accessing basic needs and services, and how they're experiencing segregation and other challenges in their community that we need to understand in order to be effectively working together to impact them. So our initiatives altogether have about 511 active members from our community. I should say, on our action teams, on our partner organizations. It doesn't include the folks in the community themselves who are working on it. We have shared action plans, so our action plans detail all the things that the different partner agencies are doing, because again, we know that we need that overlapping additive activity of various partners in order to achieve community level change. And our local philanthropic organizations have aligned their funding with these shared plans. So the United Way, our community foundation, our community benefits through the health system have said, show us how you're working together through these common networks to achieve your outcomes, so that we know we're not funding programs that are putting in place more resources or activities that aren't actually affecting systems change, aren't changing the structures, the rules, the mindsets of the community that are creating these lasting problems. So I'm just going to show you, because we've been doing so much work over so many years, in the time that we have, I just want to focus in on a few of the strategies. And so this is kind of a snapshot of a set of strategies that we've been working on recently that are focused on reducing unmet need that results in poor access to services and care, and results in, and the symptom that we identify as a result of these is high emergency department utilization. So what we focused on is sort of one of the obvious system change targets or drivers of this, which is how people have access to care, how we're triaging their needs and making sure that they're getting connected to the correct level of care. We're focusing on the culturally competent and client responsive systems. So again, really making sure that we're engaging the populations experiencing the problem and designing the solutions so that we ensure that we are, as providers, aren't presuming how the experience needs to change. We're focused on affordable community-based assistance with basic needs, and I'm going to talk about one of those strategies related to that specifically, and then I will also talk about our projects around effective screening and identification of root causes. So if somebody comes in the emergency room with abdominal pain, if you treat that abdominal pain and don't pay attention to the rest of the life experience of that individual, you really haven't addressed their need, and they may likely be back again with that same symptom, which hasn't addressed their root cause. And then I'm going to talk very briefly about some of our community resourcing initiatives to focus on how we're looking at the financing for the systems and changing that to better support a community-based systems change effort versus an acute care model where we are continually funding sort of the rescue services. So the first example, and I tried to choose different examples that were that we went about different ways to create. So this community living room was really more of a grassroots effort. So it was the folks who were working in housing, in Department of Human Services, and identifying the impact of loneliness on some of our affordable housing members and coming together to try to design a solution based on how the residents themselves would describe their unmet needs. And so what resulted from that process was a community living room, which was created within the affordable housing location, one of the largest in the city of Jackson, where people could come and gather both for to address a social isolation, but also as they're starting to interact in that setting, we are providing navigation services, community resource specialists who are interacting with them, engaging in social determinants of health screening, and then really doing boots on the ground coordination to help them. You know, they don't have enough minutes on their telephone to make the appointment, to wait online, wait on hold forever to make the appointment, or they don't have the transportation they need. So really kind of helping them, and we've identified folks from the community to serve in these capacities because our professionals don't know all of the resources the same way the folks who are embedded in the community do. We also have our paramedics, community paramedics coming there every day. 5 to 7 was our peak emergency department utilization from there. So what we could do is I have our paramedics on site there so they can deal with, the residents deal with their issues and then connect them to resources. And of course, they're going to units, and every once in a while we actually need to transport somebody to the emergency department. But we've really seen the emergency department utilization drop because people weren't getting their needs met where they were. We've had about 400 people a month visiting this community living room. There's about 300 units in the space. It is open to the public as well, so you can see that most of the people who are living in this are using the facility, and it's only been open for a few months now, so really seeing positive outcomes. And we're starting a second community living room. The residents in the community have chosen the location and are decorating this one themselves, and they are stepping up to do things like they keep the living room open longer hours than we originally had it staffed for, because they really are seeing the benefit of it. So that's kind of more of a grassroots one. This is a sort of large-scale system change in our community clinical linkages project, where we've been working on embedding social determinant screening throughout our clinical settings as well as our community-based agencies. So this is something that's took a lot of coordination across the agency work, a lot of IT integration, so that as we're doing screenings on social determinants of health, which we never were in our health settings, that we have a system where folks can be automatically referred through an electronic system to someone who will follow up with them 7 times if they need to make sure that they got that need met. Our doctors can't ask those questions if it's on them to solve them, because they can't solve them. So to have a system where they can ask those sort of questions and have an electronic referral system, just like if you order an x-ray, you get a result, then to be able to do that screening, make a referral, and know when the need has been met. And our navigators are trained to follow pathways so that when that need has been met, they identify the next need, and so on. And that IT hub system interfaces with our electronic health records, so in the process of integrating with our electronic health records, so that we're collecting information both on the EMR when they're seeing physicians, and in the community hub when they're seeing the social service agencies, and then the information is fed back and forth. That closed loop is really important. I do want to spend just a minute talking about community resourcing. So we have 2 different initiatives going on that's focused on that. One is focused on the amount that our county spends on a residential placement for youth that are in foster care or the juvenile justice system. And so what we're doing is a really deep dive with families who have experienced this system to identify where the system is failing and bring together the appropriate folks to make changes in the system design to mitigate those types. So it's really a pilot, and the premise of the pilot is that if we're able to identify the savings that we would capture to the county from preventing such high residential placements, that we can reinvest that in ongoing work that will further benefit the families to create that kind of positive cycle. The other place where we're focusing on that is with our employers. So we've engaged our local employers in looking at how they would like to engage in healthcare versus how the system has it designed, where they're jumping from health plan to health plan year after year because they are chasing the lowest premium, and the health plans are undercutting each other to get their business one year and then increase their rates the next year. So we worked with them to create a pilot where our clinically integrated network will care for their patients, will use the social service navigation system, the care management systems to optimize the outcomes for their employees. And then again, with the idea that those we're sharing in the savings. So our providers are working not only with the best quality outcomes in mind, but also with the best financial outcomes in mind, and that those savings can be reinvested. We partnered with HAP on that as they entered the Jackson market. So we've created a Jackson Health Network Select product that we're engaging with employers around. I'll skip this one because I kind of talked about this a bit, but obviously the larger scale concept is that as a community, if we're able to identify where we should invest our resources together, that we would have more impact than if the savings are going to health insurance or a system or a governmental system outside our community, which then those savings they're very happy to receive, but as a community we don't necessarily benefit. So really figuring out how to capture those savings and reinvest. And there's a lot of savings to be had if you think about the amount of waste in the acute care system as the way we currently do things. I'm not gonna, I think, we've been doing this work for a long time, so we have some outcomes that we show. Infant mortality was one of the first initiatives that we started to work on, or that blue line where we were above the state for many, many years, and now have been sustainably below the state level. We also have improved our county health rankings. So you can see that purple line is kind of the going up is better in that model. So I have listed lots of contact information for folks, and because I gave such a high kind of level view of what we've been working on, that if folks have questions, I encourage you to reach out. And I'm happy to take questions for a few minutes. Sorry, I rushed at the end. I'm getting red flashing your overtime notice. So Anyone have questions? Yes, I think there's a microphone right next to you too, if that would be helpful.
Hi, Amy. I'm Barbara Bloom-Alexander. I wanted to know if you have a name of the social service or the community health record or whatever you call it that you're using, and are you integrating it with Epic? Is that what you're referring to?
Yeah. So yes, we are integrating with Epic. The name of it is the Jackson Care Hub, and that is because we developed it. So we worked with some experts in the area who have done that type of work. It is integrated, fully integrated with our 211, our Community 211 resource database, so that as the navigators are working, they don't have to work off homegrown lists. They have access to all that database. And then the agencies are signed up so they can receive referrals. So what we really needed to develop was the connectivity between the agencies and the platform for that, and it is being integrated with Epic.
Congratulations.
So happy to share any of those learnings further. Any other questions? Yes.
Hi, Amy. My name is Sajida. I'm with Meridian Health. I was just curious, can you explain a little bit more about the feedback loop you were talking about? So what we do as a health plan is we do identify social determinant of health needs for our members, and we send community health workers out to the members' homes.
Yeah.
But one of the things that we've been struggling with is finding how to ensure a feedback loop to make sure that when we do refer members to community services, that they're actually getting the care that they need. Can you speak a little bit more on how you guys do that?
Yeah, so that hub system that we created, what it does is when the screening is completed, whether that's at a community agency or at the doctor's office, that goes into a centralized hub system so that every other provider who's on that system can see, oh, this need it's already been screened for and it's been identified. And then an automatic referral is sent to the agency, so the agency will see in their inbox, we have someone identified with a need. They'll reach out and connect with them, and then they'll document back into the hub system whether that need was met, whether they need more navigation services, or whether that need was complete and an additional need has been identified. And that information is shared back into the hub, and the agencies, including the physicians, have access to that. So unlike the X-ray, they get a kind of a closed loop that they know that was complete. And we are working with our local Meridian community health workers.
Great, thank you.
So, this is really nice work, and it's really nice to see the health system doing this. But have you seen a measurable impact on, I guess, things that would affect the health system, like readmissions?
Yeah, so we are looking at, yes, so our readmission work has been very effective. I didn't talk about some of the specific initiatives that we're doing working with that population. For the ED population, that I did describe some of that, we are doing the heat maps to look at the places where we saw hot spots initially that led us to work with the community to develop the community living room solution to look at that. Again, we've only been in about 4 months now, so to look at that again. So absolutely. I just shared some of the high-level outcomes, but not some of the specific programmatic, just because there's so many programs, or I shouldn't call them programs, because they're system change initiatives. But to track the outcomes for each of them, we do have metrics. And one more question? Okay.
Hello, thank you. Very interesting presentation. I had a question about your community living rooms, because it seems like an initiative that would help you with, you were saying, less readmissions and people feeling like maybe their concerns are heard.
Yes.
So how did you develop that strategy in terms of, you must have needed space for that? Do you use other community partner organizations? Do you set up like office hours? And, kind of how do you staff that? And I can see that you would find the money maybe from those other initiatives where you're taking the money from less patient readmissions and being able to fund that, or how does it work in terms of space and
and most of our initiatives are not run by the health system. So what we're doing is bringing people together. So it was the Affordable Housing Commission who identified, we have a community space on our campus, but people don't go there because there's nothing for them there. So we were able to repurpose that space And then we were able to identify through our community action agency resource specialists that are the same type of specialists that do housing navigation assistance. So they're very familiar with identifying need and integrate that model. And then our community paramedics. We did get grant funding to support the initiation of some of that work. And but we, again, had a lot of community agencies who were bringing resources. So our Federally Qualified Health Center brought one of their case managers on site. So they're connecting people back to primary care there. They don't want to do all the case management on site. They really want to create that relationship and then be able to serve that person in an ongoing way. And we did bring to our health system board and talk about, from a sustainability perspective, the funding that we're able to save to reinvest in the ongoing needs of that will be key. But a lot of those needs are being met by community agencies that are using their resources in different ways to meet the needs of the population.
Thank you.
Thank you very much. And I think we're starting with panel 1 next.
Good morning. Thank you, Amy. I just want to say very briefly, I'm a nurse in the area that you serve, and I can speak to the reputation that the Henry Ford has in the area in Jackson County, and I'm hearing really positive feedback from the community. So I think that's an outcome, too, that you can anecdotally measure. So good morning, everyone. Welcome to panel 1. This panel is about air pollution. My name is Kendra Wide. I am the coalition coordinator with My Air, My Health. I'm also a practicing critical care registered nurse. I work in a medical ICU in Southeast Michigan, but not Henry Ford. My Air, My Health is a nonprofit organization that brings health professionals such as yourselves together to advocate and educate about the health impacts associated with outdoor air quality, specifically here in Michigan. And today, I am honored to welcome our 2 guest speakers. We have Dr. Beatriz Cardenas and Mr. Guy Williams. Their 2 presentations will be followed by a 30-minute discussion and wrap-up, where we will take questions from the audience at that time. So please hold your questions until this period. And then if you'd like to ask a question, you can use the microphones that are situated throughout the auditorium. But very briefly, I just wanted to talk a little bit more about the work that My Air, My Health does before we get to our presentations. We connect health professionals, like I said, such as yourself, with key decision makers to educate them on the downstream health impacts of the policies and the decisions that they're making. Specifically, we focus our attention on policies related to emissions from energy production, transportation, and heavy industry, and the public health impacts associated with those emissions. So as a nurse in a medical ICU, I take care of patients all the time with chronic heart and lung conditions. Some of these patients have COPD, congestive heart failure, asthma, and they are often in my medical ICU because they're suffering from an acute exacerbation of their chronic condition. And this is sometimes due to, related to poor air quality, such as ground level ozone levels and particulate matter. And we often see this a lot on high heat, high temperature, poor air quality days in the summer. So there's, as you all know, I'm speaking to a public health oriented audience, but there's an extensive body of research that links air pollution exposure to several negative health outcomes, not just the ones that I've mentioned, but also various cancers, dementia, cognitive disorders, conditions associated with inflammation like diabetes and stroke. So often the policies that we see, if any of you do any sort of policy work or health policy work, we know that they are often sort of short-sighted. and written without consideration of their downstream health impacts. And it's important for us as nurses and as health professionals to advocate for our patients, not only inside the hospital setting, which we are all familiar with, but also outside of the hospital setting. We can treat our patients inside the hospital and get them back to a state of health, only to discharge them into the very conditions that sent them into the hospital in the first place. I'm sure many of you are aware of this. So that's why I'm interested to hear about the interventions and research that Dr. Cardenas is involved with around air quality in Mexico City, and to hear what sorts of policies have been effective in reducing emissions. And then I'm also always interested to speak with Mr. Guy Williams about vulnerable populations and environmental justice, because we know that these exposures are not evenly distributed throughout the population. So I will move on to the presentations. I now have the honor of presenting to you our first speaker, Dr. Beatriz Cardenas. Dr. Cardenas is the Air Quality Management General Director of Mexico City's Ministry of Environment. She's been in this position since 2017. She holds a Certificate of Advanced Studies in Environmental Diplomacy from the University of Geneva, a Master's of Science and PhD in Environmental Engineering from the University of Massachusetts, and a Bachelor's in Biochemical Engineering from the Autonomous Metropolitan University in Mexico. Her experience in environmental policy, particularly in air quality and short-lived climate pollutants, includes working as an air quality project leader at Centro Mario Molina in Mexico City, and previously as part of the experts team at the Megalopolis Environmental Commission for the Central Region of Mexico, advising on public policies and overseeing several air quality projects. For 12 years, she led the atmospheric pollution research at the National Institute for Ecology and Climate Change. She has participated in several research projects, including major campaigns in Mexico City's metropolitan area in 2003 and 2006. And between 2007 and 2017, she received the distinction as National Researcher 1 from the National Research System in Mexico. Dr. Cardenas has participated in the Mexican delegation at the IPCC, CCAC, Stockholm Convention Experts Group, and CCE. Please help me in welcoming Dr. Beatriz Cardenas.
Well, good morning, and I will first like to thank all the organizers. Really, thank you so much for all the help and follow-up during the last months. Such an honor to be here representing the Mexico City Ministry of Environment, that I will share with you some of the experience we have had in air pollution policies. So, well, this is a picture that we choose about Mexico City. When we talk about Mexico City, we always talk about the huge metropolis. But in fact, Mexico City as a state, it's the color part that you see in the map. But we are surrounded by 59 municipalities that belongs to another state. All together, we make up to 20 million people. But Mexico City, so those are like a state of Mexico. We have 12 million people. And Mexico City has 8.8 million. So the whole metropolitan area, it's a little bit more than 20 million. Even though we are different states, we share the same airshed. So air pollution doesn't have any borders, so whatever is emitted in one place, it travels, it transforms, and it deposits in another place far away where it was actually emitted. So that implies that we have to have a very good coordination between not only the two states, but also the municipalities, both from Mexico City and the state of Mexico, but as well with the federal government, because some of the sources that are either in Mexico City or the state of Mexico, they are not controlled, or they are under another jurisdiction, which is the federal government. So as you can imagine, it's a quite challenging issue for a city as Mexico City. The green part that you can see in the central part of Mexico is what we call conservation land, which is very, for most of you will be the first time that you hear about it, but Mexico City land, I mean, it's a huge area that is conservation land. So most of the 8.8 million are actually living in 40% of the land. So can you imagine how densely populated it is? Mexico City has 2.3 million registered in Mexico City, but in the whole metropolitan area, we have more than 5 million cars. Even though we are a lot, we have a lot of cars, the motorization rate is not as high as other places in Mexico. So we have 1 car per every 5 people, approximately. But of course, all these cars are coming and getting around the city. We also use a lot of fuels to run these vehicles. So most of our energy consumption goes for fuels to move these vehicles. Private vehicles, public transportation vehicles, as well as load vehicles. We are mainly using for houses, for heating water and for cooking. We are mainly use gas, both LPG and natural gas. And I'm saying this because, yes, when you have such a large population concentrated in this area, of course, how you cook, how you travel, that makes an impact on the emissions. We have about 6 million homes in the whole area. And what else I can say? Well, you will see that later on. Oh, I will say that, well, Mexico City is 2,000 meters, 200 meters, 2,200 meters altitude. We have radiation, solar radiation most of the year, so we have a very active atmospheric chemistry that produces secondary pollutants. We have, even if we have during the summer, we have a very heavy rainy season, most of the year we have sun, a lot of sun, which is good for one side, but the other one, in terms of air pollution, it actually makes another issue of air pollution for secondary pollutants. Since we are in such a high altitude, we also have problems with combustion. We have less oxygen, so that makes combustion more difficult. And we are in a valley, so we are surrounded by mountains. So we generate a lot of pollutants, and we actually depend of the air, of the wind, to disperse the pollutants. If not, we do have a problem because all the pollutants that are emitted during the day, they get stuck, they concentrate, and of course we have some problems. So our main issue now is not only the emissions, but also be aware of the conditions of the wind. There are some pictures of Mexico City metropolitan area. So when I talk about Mexico City, I referred only to Mexico City, but the whole, as you see, is metropolitan area. But this is just an example. In 1972, Mexico City was actually, in 1992, sorry, it was actually declared as the most polluted city in the world by the United Nations organization. In that time, we were growing. Of course, it was the capital of the country, so it's the most populated area in the country. We started having a lot of cars coming out. In that time, the cars didn't have the catalytic converter as many other places in the world, but we actually, it took us longer to get the catalytic converter. We also used to have a refinery in the north part of the city, inside Mexico City, a refinery. And of course, it was not a new one, so can you imagine the amount of pollutants that were actually being produced? And in 1991, it was actually declared that the refinery will be closed because of the high index of pollutants that we had. This is an example. I'm going to talk a little bit about the cars because in Mexico City, our emissions inventory shows that the main pollutants come from vehicles. So the blue line, it actually it's the record of the fleet, the vehicle that are registered in Mexico City. The green one is the whole metropolitan area, the state of Mexico and Mexico City, and the gray one, it's actually for the state of Mexico. So as you can see, Mexico City fleet register, it's actually going down, and that's because we do not grow up so much. The population is actually stable. We have a good transportation system. And some of the cars are actually being registered in another state in order to avoid some of the restrictions that we have in Mexico City. But as a whole, the metropolitan area is growing a lot, so the fleet are actually, it's been increased. Most of this fleet is private vehicles. And people, about the whole number of trips that are made every day, only 1/3 of those trips are actually done in private vehicles. But we have a lot of vehicles going around. So in terms of equity, again, the pollution is coming from these vehicles, all of this, but only 6% is coming from public transportation, even though they are actually transporting 2/3 of the population. So that's a big challenge because you have most of, as you will see, a lot of the interventions and the actions that we have implemented are focused on vehicle fleet. But that's a big challenge because no one wants to leave their car, no one wants to be regulated about the car, and also it's important to mention that this fleet is actually being increased over the years, but we don't have the best technology. Our federal standards are so relaxed that we are able to have a 2018 car with technology that is at least 10 years behind what you will find in the US and Europe. So even if they are new cars, some of these are new cars coming out, which is the case of Mexico City. Our fleet is about 6.7 years old. It's the newest fleet in the whole country. Well, those new cars are not coming with the best technology in terms of control of emissions. So one of the big questions is that, in 1992, Mexico City was the most polluted city. How that has changed? It has changed a lot. And Mexico City has a very extended air quality network. It's actually one of the oldest one in Mexico. And it has actually been expanded. It has been evolved over the time. So we have data for more than 30 years that actually can show that, yes, air quality has improved. And this is just an example. This first line is 1990, and the last one is 2018. And each square is the highest concentration that was recorded for ozone, and this is for PM10 that day. And we just use the colors that we use for our air quality index based on our current standard. So that means that our standard calls for above 95 ppbs per hour of ozone. That will be bad air quality, and that will be a orange color. And if we about above 155 ppbs, there will be a red, and if we are more than 200, we will be purple. The recommendation for the World Health Organization is about 80 ppbs. So we are a little bit behind, above of those. But if you see, in the 1990s, you will have days with not only bad air quality, like the yellow one, you will have purple most of the year. And that, to our own, or today's standards, that will require that we will be on contingency. We call the very heavy, high pollution day, that we have to implement many actions. And that will be phase 2 now. Over the years, the air quality improved, and we are having less and less those purple days. In 2016, we have a purple day for only 1 hour, but once we reach that concentration, and if we have for the next day a forecast for bad air quality, we will declare phase 1 or phase 2 contingency. That includes a lot of actions, such as some industries have to stop production for 30% of the production. Industries in the metropolitan area. That's a program for the whole metropolitan area, not only Mexico City. And the vehicles that have a sticker 2 or 1 that is based on the emissions, they will not be able to circulate. up to now, most of the, up to 80% of the cars in Mexico City have a sticker 0. That means that they could circulate every day. But the 20%, the other 20% have either sticker 1, they are not able to use their car once a week, and the sticker 2, they are not able to use their car twice a week. And if there's a day of contingency, sticker 1 or sticker 2 are able to circulate. A car with a sticker 2, if you measure their emission, it could be up to 20 times the emission that are allowed for a sticker 0. So that makes a lot of, even though they are less and less, the impact of not allowing them to circulate, it's a lot. Not for traffic though, but yes, for emissions. So for PM, we are also getting better. So if you see, before the whole year, it was ozone day. Over the years, fortunately, ozone period, the highest concentration that we have is for spring, is between February and June, just before the rainy season comes. And that's why, why we have this highest concentration, because in these seasons we have some stability system, high pressure system that makes that the wind is very calm, so the pollutants are actually get it concentrated, and we have a high radiation, the highest radiation, and no clouds in the sky. So that means that we have a lot of energy to produce a lot of ozone, and we have the precursors, and they stay there. So those are the highest concentration that we are experiencing. But that changed. In the past, we have ozone the whole year, and that's a big challenge because, of course, we cannot change the wind patterns, but we can change definitely the emissions. Well, this is another example of how air pollution has been changed. Before, the compliance days is those days that we are above the 95 ppbs per hour. This is just 1 hour. Well, in the 90s, as you saw in the mosaic graph, we have like almost 450 hours, but this cannot be days, but this is hours. And then the contingencies, well, yes, in the 90s we will have a lot of days of contingency 1 or contingency 2, and over the years, fortunately, those are even less frequent. But we still have some days. In 2016, we have a very bad concentration days. Well, this is the number of days in which we have this concentration of above 155, which is a lot. And how has this been done? Well, we have an air quality program that was actually implemented since the 1990s, and it's a coordinated program in which both the state of Mexico City, the state of Mexico City government, as well as the federal government get all together, identify where are the sources, and implement a plan. So what each of them should do in order to reduce emissions. They have some goals, although they are very general. They have some schedules, and there is a plan that is being agreed. And of course, that includes some of the actions, such as this maintenance inspection for vehicles in Mexico, since, well, it has evolved. It started in the 1990s, just to check if the cars were not emitting a lot. And now it has evolved to each owner of a car in the metropolitan area of Mexico City has to take their car twice a year for vehicular inspection. But it's not vehicular inspection as you have here, which is like physico-mechanical condition. This is for emissions. So we have each car are actually tested, and their emissions are measured, and based on those emissions, that's what you get the sticker. We have this Hoy No Circula, which is if based on your sticker, then you cannot use your car every day. And we have also these contingency programs. Once we reach this number, there's the whole declaration, the phase 1 or phase 2 is declared, and as you can imagine, this goes as a very important issue in the media and for all the government agencies. So the health standards that we have, so little by little, are getting more equal to the recommendations of the World Health Organization. We're a little behind on NOx and SO2, so every 5 years the standards are reviewed and try to make up to what is recommended. We are not so good in industrial regulations. Mexico in general are not very relaxed in the standards. The big standards were, the most important standards were actually published in 1993, where the North America Trade Agreement was actually signed. So in that time, all the regulations were actually kind of harmonized, but over the years they haven't been updated. So we have a good emissions inventory in which we keep track of who is emitting when and how, and that helps us also to identify those sources that are very high emitters. And since last year, we have an air quality forecast model, which helps us a lot in order to know how the conditions for next day is going to be. And of course, all these tools help us to. So this is the air quality system that helps us to inform people. We have an application, a mobile application that we have on our webpage that I really invite you to check on it. All the information is open, so the data is there. We have in our application, there is also the forecast for next day and some recommendations for the people what to do. Based on their quality, what activities are recommended not to be done. Even though that it's getting more known, this application, we know that most of the people do not use it for preventing of doing some activities that would make them a higher exposure. They actually look at if they will circulate or not the next day. We definitely have a big challenge to change the mind of people. We are more and more aware of the meteorological conditions in the city. During the rainy season, if you don't know if it's going to rain, if it's going to rain heavy, then you can get stuck and even floating. But for the air quality, it's also important. Tomorrow, it's not going to be any wind, so then it's going to be a bad air quality situation. We have this model that helps us to know what is the air quality for the next day. This is a big. Really, it may seem simple, but it took a lot of years, and finally we are able to have such a good air quality model that needs air emissions data as well as air quality monitoring in order to know that if your forecast is doing well or not. And we are getting a very good performance of the model. So as you see, this is a day in which certain hours of the day you will get the red color, and that means that it's a lot of ozone that you will be exposed to. What we have been using this model as well as just to know what if we do this and this. It was trying to model the day in 2017 that we have a very high ozone day, and what will happen if we do or not do any actions. And that helps us a lot in terms of policy making. Actually, to convince many of the sectors that do not want to do anything because they don't believe that air quality is actually, they are part of the air quality problem. This is emissions inventory. Mexico City has an updated emissions inventory every 2 years, which is, it helps us a lot just to identify what are the sources. But also over the years, we have been able to integrate air quality emissions inventory or air pollutants emissions inventory with greenhouse emissions inventory, which is another step in terms of policy. Instead of just having two policies for climate change and air quality, well, they are all interacted. It sounds very logical, but that doesn't happen in other parts of Mexico, actually. So in Mexico City, fortunately, the Ministry of Environment is well aware, so all the policies are kind of correlated. These are the programs, and I'm running out of time, but let me just, our program allows to know which action actually did the best thing in terms of the best success in terms of reducing pollutants, and that also allow to identify what actions are the best. So as you can imagine, most of our sources is still vehicular emissions, so the programs that are related to control emissions for vehicles are the ones who actually contribute the more to reduce. That is difficult to convey, to communicate, because as I mentioned, people don't think that their cars are actually contributing to emissions. So those are the programs that we have for vehiculars, the inspection, the restrictions to circulation. We still have some cars that have the previous catalytic converter, so once they are actually run out of life, then we have to make a replacement. That's little by little, but we have a big problem with diesel vehicles, because most of the diesel vehicles that are circulating in Mexico City, they are actually from federal plate that we cannot control. So I just wanted to get into this very quick. This Tuesday, we actually have a presentation of a project that I think it will be of your interest. There was a study done by Mexico City Ministry of Environment in collaboration with the Harvard School of Public Health. It took 4 years to do this study, and what we wanted to do is to evaluate what are the health impacts of in Mexico City health of the population, considering the 1990 to 2015 reductions of air quality. So we wanted to estimate the health benefits of having these reductions. And this is just, the report is actually online. I have some cards if you want to just to take the address, the web address, and you can download the integrated results. But as you can see, this is a map for every year and each part of the city. And as you can see, in 1990s, that will be the concentration, the highest concentration of PM 2.5, and this is how it looks now. So over the 25 years, we were able to reduce from 36 to 21 micrograms per cubic meter. We are still high above of our standard. Our standard is 12 micrograms per cubic meter per year. So yes, we have done some progress, but we still have a long way to go in order to reduce the concentration. But all the result, what it shows is that looking at the ozone and the PM 2.5 reductions, because of these reductions, Mexico City avoid the premature deaths of 2,500 deaths that will have occurred if the concentrations were the same. This is good. This is a very robust analysis, and we hope that our colleagues that are coming from the next administration, both national and local, will take this into account and will actually implement even more actions. The other good news is that, yes, if you look at life expectancy in this period, it was we gained some years of life, and one part important of this, the contribution of this was, of course, air quality, among other things. But yes, air quality in the study, when they separate other causes or other changes, air quality showed to be an important one. And this is another one that I was just listening to Amy, and I got some ideas. How can our main challenge now is to implement this health risk index. What we did, we wanted to do an index that is very unique. I mean, that is considering the conditions of Mexico City population and air quality. So since we have data from both, from air health information and air quality over this time of the year, for a whole series of time, and as well as we have we are able to cross this data, then we are able to do an index that is specifically based on the emergency admittance to the hospital that you call. So we were able to identify a model that, yes, when we have high concentrations, then we know that the following days we will have admittance to emergency in the hospital because of asthma or other type of illness. And since we do have the forecast, then we are able to know tomorrow what will be the index in terms of the risk, health risk. So we are trying to implement this, but of course, since we are environment and we are not health, so it's difficult how do we implement this. We actually get along with the Ministry of Health in Mexico City. We propose, let's do this, and they say, oh, that's nice, but you know how much work we have. So why don't you just have an application and ask everybody just to report what they have, how is the condition tomorrow, and how they will use this index. So the idea is that instead of having this index that only tells you what is the highest concentration for tomorrow of one pollutant, this is an integrated index that will tell you, consider PM 2.5, ozone, and NOx, and the conditions that we know the health data that we have, then you will be able to know tomorrow will be a day with a 10 index or a 4 index or whatever, but it's integrated. And the idea is that people know what is the net number that you actually start experiencing some health issues. So that's a challenge. And we are also part of the Breathe campaign that WHO is having in many cities of the world. That the idea is to commit, to make that the governments of different cities actually commit to do some actions in terms of air quality and actually make more aware different sectors that air quality is a problem. And that's it. Thank you so much.
Thank you very much. Oh, no, that's fine. That was great. Thank you. I can't wait for questions. Next, I would like to introduce our next speaker, Mr. Guy Williams. Guy Williams is the president and CEO of Detroiters Working for Environmental Justice and principal and founder of G.O. Williams and Associates, LLC, Strategic Advisors for Sustainable Community and Environmentally Related Programs. The recipient of the 2017 William Milliken Leadership for the Common Good Award and Bucknell University's 2016 Alumni Association Award for Service to Humanity, Williams was also named 2014 Michigan Green Leader by the Detroit Free Press. He is Chair Emeritus of the Great Lakes Leadership Academy Board of Governors, a director on the boards of the Rails to Trails Conservancy and Pesticide Action Network North America. He also serves on the advisory board for the Center for Urban Responses to Environmental Stressors and the Great Lakes Integrated Sciences and Assessment Center. Please join me in welcoming Mr. Guy Williams.
Hey, good morning, everyone. It's probably pretty evident that technology is not my major. I was mystified by being in the middle of Dr. Cardenas' presentation here. If my mother were still alive, she'd want me to record this so she could know what I did today. So first off, I just want to say how glad I am to be here, and I want to thank Kate and Dana and the rest of their team for inviting me to be here. And I want to acknowledge my friends Barbara and Chip, and I don't see Dr. Kimberly Dawn, but I believe she's around here somewhere, certainly in spirit and solidarity. And I'm curious, how many of you actually work for the hospital system? I want to get a sense of the audience. Thank you. And others, are you students, med students, a little bit of each? And then I saw one of my friends, Tim, and I think maybe back there, Tony, yes, his colleague. They are long-term friends and supporters in the environmental movement, and they are co-sponsors. Their company, AKT Peerless, is a co-sponsor of this event, so that's exciting. And I thought I saw my colleague Layla Mikias, who did a lot of the work I'm going to talk about here, so I'll be sure to give her a shout out. She works at the health department now. So that last point about coordinating between health and environmental agencies is a very important point. Let's see if I can figure this out. I guess basically what I wanted to share today is two main themes and a little bit of context. The context is, for those of you who don't know, a little bit about what the heck is environmental justice versus injustice anyway. Why am I here? Why is my organization started back in the mid-90s as the first environmental justice organization in Michigan? And why is it 20-some years later, we still have so much work to do? That is a problem. The other thing I want to share, I want to give you some facts, share some research from one of the collaborations we're in, and then a framing of solutions and proposed solutions that we have set in motion. So let me see here. Click. Oh, look at that. Awesome. I apologize. Some of this may be hard to read, but maybe what could be helpful in this age of Googling and easy searching, I'll try to point out a few things for you to write down for future Googling, and then you'd have the best notes. And one of them would be principles of environmental justice. There are 17 of them. They were established in 1991. They were written over a series of almost 20 different drafts that was ultimately ratified at a convention of 550 delegates from all over the country. And I just want you to pause for a second and imagine agreement over 500 people on 17 statements. I mean, think about that. It's a miraculous document. I was blessed to be part of writing the early drafts of this. And it's something that still stands today, that those of us in the movement refer to, we work from. It helps us have a solidarity across our activity. And I wanted to highlight two of them for today's conversation. Principle number 2, environmental justice demands that public policy be based on mutual respect and justice for all peoples, free from any form of discrimination or bias. And number 5, environmental justice affirms the fundamental right to political, economic, cultural, and environmental self-determination of all peoples. And given that we're about 3 weeks away from our general elections, this one is particularly on point because what we know and what I learned early in my career is that the array of policies that are in place or the lack thereof directly impacts the day in, day out living conditions we have here. I call it the rule book because I need to simplify some of this technical stuff for myself. So we need new rules if we want different results in different conditions. And that primarily is what Detroiters Working for Environmental Justice is all about these days. It's getting people up to speed on what the rules are, how they impact them, and what can be done about them. And I see Layla's back. Hey, Layla, I wanted to brag about your work soon, so glad you're back. I guess I can't say next slide to myself. First off, I want to go into some of the research. We have a great team that's a community and academic team based out of University of Michigan, and it's called Community Action to Promote Healthy Environments. CAFE is our slang name. And if any of you have ever been involved in funding from National Institutes of Health, you find that these catchy names are the way to go with them. So ours is CAFE. And I'm going to whip through some of the research, and I want to credit Stuart Batterman for helping prepare some of these slides for a different presentation, but I thought it's right on point for our purpose today. And I need to give a shout out to our funders, NIEHS, and locally our Fred A. and Barbara Erb Family Foundation for our support. So one of the key things in our work locally is that DWJ really tries to work as an aggregator of organizations. And in this case, the University of Michigan has served as the aggregator, and these are logos of our primary partners in the CAFE project. There are many parallels in our air quality conditions here that we heard in the previous presentation. One of the things, though, that's very different from what Dr. Cadenas was sharing is the mix of chemicals, the mix of sources, and the regulatory challenges that brings us here, an opportunity for new rules. We have we have a lot of pollution from traffic, we have a lot of pollution from manufacturing, we have a lot of pollution from energy generation. And I just want to pick on one pollutant, which actually is generated from all of those different sources, sulfur dioxide, because sulfur dioxide is one of the chemicals in our area that our National Environmental Agency has found that we're exceeding the proper standards, or the nomenclature there is out of compliance. So if you look at the chart, let's see if I can use this fancy. This is Detroit, the city limits of Detroit. And then here's what we call our downriver suburbs. And notice the concentrations going right through the heart of the city of the most intense of this type of pollution. I also want to point out, if I can, where we are right now is somewhere about here. If we were on the 5th or 6th floor of the building, we could look just out here about a half a mile and see one of the largest municipal waste incinerators in the country at work. Many years ago, one of my colleagues, Bunyan Bryant, and his colleague Elaine Hochberg did a study of the prevalence of low birth weight babies in the city. They found that this zip code, right where we sit today, has the highest incidence of low birth weight babies. Is it because we're right near the incinerator? It's hard to tell. Is it right because we're near the confluence of 3 major interstate highways? It's hard to tell. Is it right because we're near a bunch of homes with lead that got torn down and put lead dust everywhere? It's hard to tell. Is it because we're near the east side where historically there were 6 active lead smelters spewing fumes all over town, particularly over in this part of the town? It's hard to tell. But what we know for sure is all of those things are going on simultaneously. And this is where there's a major gap in the regulatory protections available for us in Detroit and everywhere else in the U.S. These are the issues that we at DWJ would like you to take up when you're attending candidate forums, when you're in contact with candidates. Get them aware that this is the case. We need a new normal. Or as my friend Emma Lockridge says, why are we stuck on stupid? We know better today as a society how to deal with these things, but we just don't do it. One more slide, which is an overlap of the amount of pollution people are exposed to and the health risk, which is an indicator of the level, the density of vulnerable people, meaning babies, expectant mothers, and elderly that live in those areas with high exposure. So again, the city of Detroit is almost entirely red. But not only that, the suburbs are not really safe havens that they may think they are. We have a lot in common all across the metro area. And the slide for me that's maybe brings it home most succinctly has to do with the hundreds of people we now know are dying every day in our area. Whoops, wrong button here. This number right here. Basically 700 people a year, 2 to 3 a day. We now know that we can attribute those deaths to illnesses related to air pollution. We don't know which 3 people are dying today, but we know it's somebody, and we know it's avoidable. So what I try to do for myself is I try to keep a bit of a face on the situation and not just glaze over to the number. I try to keep in mind the people in the movement like Mustafa Ali, who works nationally. I was on the phone with him this morning, and he's like, yeah, man, I'm still grinding. I'm like, yeah, I got you. Why is it I met that young man in the early 90s as an intern at EPA. 25 years later, he's still at the agency, and now during the Trump administration. So he's not in the agency working on EJ, but he's still grinding. 30 years later, we're making not much progress. And so, my entreaty to you is if you're registered to vote, please vote. If you're not registered, please get registered so you can vote next time. And along the way, get educated about what you can do. All right, here's something to Google, because I don't have a slide for it. Detroit Environmental Agenda. Detroit Environmental Agenda. When you Google it, you'll find our voter's guide, which has 5 major points that help you talk to people, policymakers, about these issues in plain language. Barbara over here has been a big champion in that coalition, and Chip, I see here, he's newly among our group. One of our main goals there is to help bring information to audiences like this and help you see in plain language what we can do and what's up. So here's what we can do that's come out of the AIR research that I mentioned. We have 10 primary recommendations. I won't read them all to you, but some that are key, particularly in the current time, are renewable energy opportunities with our new Michigan law, diesel engine retrofits. Those of you who are familiar, we're having a new bridge built to Canada. And in the meantime, the current situation, there's all kinds of trucks. We have one of the most prolific logistic hubs here in the country. You may not know that. And that's a short way of saying there's all kinds of freaking trucks everywhere and a lot of diesel pollution. That's what's contributing to this soup. So just to backtrack a little bit about the policy of air pollution, in America, each facility or each type of source of pollution tends to have an opportunity to be regulated under certain standards. In other words, they are allowed to pollute to a certain level. But what we don't have in America is a way to address the fact that all of these different sources pile on top of each other. The cumulative impact and the exposures generated by all these different sources, that is something, it's a major gap. Tools that are trying to help us articulate why this is important that relate to your work would be health impact assessments, promoting to politicians and elected officials health in all policy strategies, whereas every type of policy coming down the pike, we pause for a minute and we become just as eager to see the benefit analysis around health as we are around money. That's what a health in all policies would do for us. And I was very excited to hear that they're starting to move in that way, at least in terms of the information in Mexico, to show that when we actually increase our protection, we increase our health. That is key. I only have a few more minutes, so I'm going to whip through the next, which is our climate action plan. So Detroiters Working for Environmental Justice convened roughly 40 partners about 4 years ago, and last fall, just about a year ago, we published the fruit of that work, which is the Detroit Climate Action Plan. It's the project that I was saying Layla was super crucial to helping that come off successfully. And what's really exciting to me right now is the current administration has a new Office of Sustainability that's active. Our organization is working all across the city, drawing input on what their action agenda for the city agencies for next year will be. And we're hoping a lot of these recommendations around air quality, around sustainability that I'm going to show you in a moment, that this all starts to come together in a much more practical way. One breakthrough we had was having the mayor at the 11th hour offer us a letter of support for our document. And the reason that's so key is because Detroit has been a standout in a negative way around these issues of global climate change, for example, and sustainability. We're lagging behind. But we're just starting to catch up and get on board with other cities. I'm going to spend apparently about 10 seconds talking about climate change for those of you who don't understand it, what it's about, and how the radiation gets trapped because CO2 acts like a blanket. You probably have heard this before. To have one more visual to bring it home for you. Bottom line is we're expecting the climate here in Michigan to shift. So if you take a look, this is where we are now. What we're saying is that over the next few decades, our climate will shift so that it's much more like the climate here in Oklahoma, which means it's just basically going to be warmer and stormier. Hopefully the earthquakes won't come with it, but all kidding aside, right, it's going to have an impact on animals, it's going to have an impact on our economy in terms of our growing season. For those of you who don't know, Michigan, second behind only California, has the widest agricultural diversity of crops that are grown and distributed here nationally and globally. So agriculture is a huge, huge part of our economy. And as the climate shifts so that we can't actually grow what we used to grow and the way we used to grow it, we're going to have to change. So there's a lot at stake here. And the reason I'm bringing up climate change in the midst of our conversation today is because there are so many co-benefits around air quality and public health that can come from taking measures to address climate change. I'm only going to, I think I skipped the slide somewhere here. I probably took it out in the beginning to be short. I wanted to show you the different chapters that we have, but I'm just going to highlight two of them right now, which is solid waste and health. Health is obvious why. Solid waste not necessarily as obvious, but because of the incinerator and because of our local strategy of basically burning everything in sight and minimally recycling, this is something that caught the attention of our solid waste committee, and they've put forward some important strategies. So another thing to Google. Detroiters working for environmental justice, go figure. When you get to our website, this report in its entirety and our report about the economic impact of implementing our recommendations are on our website. It would be great follow-up information for you. Let's go to this. Our main goal and main need, I think is a better way of framing it, in the city is to set goals. The city does not actually have key goals on recycling, which might seem odd, which I believe is very odd. We have recycling available to some of the population now at curbside. We don't have it easily available for commercial facilities like this one. We don't have it available easily for multifamily housing. We don't have it available for restaurants and sources of organic waste. So these are all areas that we want to get a handle on, and we have some great opportunities in the next 5 years to redo our contracts and make great progress there. In the public health sector, the goal I picked out is to talk about increasing monitoring of climate-related health outcomes, such as heat-related hospitalization, injury or death from extreme weather events, and asthma-related outcomes. So again, I'm encouraged to see parallels in Mexico on starting to track the impact on our health as we make changes in the environment. Like, I believe those stories and intertwining those stories, elevating those stories is very key. And the last thing, I just want to leave on a little bit of a hopeful note. we do have the power to make change. And I would say also the responsibility to make change. I realized in August when I was helping a friend run for state office, and I checked the results late in the evening, and my friend was ahead by 1 vote. Ultimately, he won the primary by about 100 votes out of something like 12,000 cast. But I called him up. I'm like, Jeff, man, I'm really glad I voted today. I bet you're glad you voted. He's like, oh, yeah. 1 vote really does count. We all count. So I promise you I'm going to be voting. I hope you'll be voting with me in a few weeks. And thanks a lot.
Okay, that's great. Now we'd like to open up the floor to the audience to pose any questions. So those of you that have questions, please feel free to make your way to the microphones. It'll be for both presenters. And I guess I'll get the discussion started. I have a question actually first for Dr. Cardenas. So much of the work, and actually probably, Guy, this applies to you too, so maybe you can each chime in. A lot of the work that I do is to try and educate our legislators, and I've been doing a lot of candidate education meetings in the last few months. Well, pretty much that was my whole summer, was going around and meeting with representatives and senators, many of them who do not have health backgrounds, and trying to educate them about everything that we've talked about today and how regulations regarding air quality, regarding clean car standards, and regarding industry and transportation emissions in the state, how that impacts human health, and trying to, some of the messaging that I focus on is trying to put not only the human health piece of it, so I talk to them about some of the patients that I see over and over again for the same chronic issues, but also trying to talk about the economics of that hospitalization, because not everyone cares or is empathetic to the health or environment messaging. So I'm wondering if either of you have the same challenges in Mexico as far as regulations and what type of environment regulations are received regarding emissions in transportation, and then also what sort of strategies you've employed to be successful in trying to get candidates from both, to get sort of a bipartisan support for some of the health, for regulations that would impact public health and environmental health. So I'll start with either of you, please.
Well, yes, indeed. Educating ourselves in different issues. Yesterday and this morning we were talking about the importance of having these groups of interdisciplinary fields, because yes, I mean, if you talk to people in atmospheric science, everybody knows, yeah, the pollution, there are some discussions how much it has been reduced, but then we are lacking of data of what is the health impacts or what is the economic impacts, as you mentioned. So when it comes to this type of events, and you have health practitioners, then you have the economic part, and then you have the atmospheric science, then it's when you get all this richness. Because indeed, one of the important things is some years ago, we actually were discussing of some people in the media, they were even arguing or even questioning, where are the dead people? I mean, how do you actually prove that they are actually die because of an illness, which it sounds really incredible in another groups of people, but in the media they were saying that. I don't believe in those numbers. So then that's what we ask people from health part to start talking about. But when it came very clear to even those people who were not believing in this is when you talk about cost. I mean, even if you cannot quantify for government expenditures, is every time that you get sick or you don't feel well, then your productivity, of course, is not the same, and that is directed to your income or to the society itself. how much it costs if a kid cannot go to the school because of an asthma problem, or if you cannot go to work because you have to take care of someone, either an infant or elderly people. So that's when you start talking about what is the impact as a society that you are actually having, that's, I guess that it helps to educate and to make more sensitive those people that will either legislate or actually be in the power. But that is a big challenge. The study I was talking to you about, the Harvard, one part, once we, that the health benefits were quantified, one part of the study was what action could have some impact. And we focus on diesel trucks, actually, because that's a big issue in terms of PM 2.5 and exposure. They don't count a lot in terms of the total tons of PM 2.5, but it counts a lot in terms of exposure. So what we did is that retrofitting to identify how much it will cost to retrofit all the vehicles, the trucks that use diesel. And it came out like they will cost 93 millions US dollars a year. But when you account for the health benefits, that will go to 250 millions of, so it was more than double. So that's so clear. And then you have a lot of other benefits that you are not accounting that. So every time that we have these meetings with even the heavy duty trucks industry, either because they are the fleet who are actually transporting the goods and we're asking to retrofit and to invite them to have these programs, they always say, it's so expensive, oh come on, we are suffering too much, our revenues and whatever. But as soon as you start telling them what will be the health benefits and actually their own health benefits, it gets a little bit easier to make the discussion. So the costs are again so important.
Hey, everybody. So great question. Thank you, Kendra. I quickly whipped through that chart with the numbers about mortality, but what I didn't speak to was hours from work and school lost and the impact of productivity. I believe somewhere in the average of 15,000 work hours are also lost for illness, which we now calculated at more than $6 billion of an economic impact of a drag on our local economy. So as you were saying that the way we can frame the information is beginning to help make inroads, particularly with state level legislators. And also want to give a shout out for our Detroit Environmental Agenda and its strategy with local elected officials here in Detroit, which I feel has made a big difference. I mean, I've been working here in the city since the time when environmental justice was really a nasty phrase, and elected officials would not talk to us or answer the phone because they thought we would threaten the big three and anything that had to do with local economy. And we've progressed to an era where city council members reach out to us proactively because they want to introduce legislation to protect health. And they want to know what's the best way and what are the best sources of information. So that transformation was spurred quite a bit about 5 years ago when we created our first voter guide and opened up dialogue between candidates and residents in their districts and provided talking points and took them on bus tours and helped them see firsthand what was up, what's at stake, and what's possible. So it's taken multiple avenues to bring about political change, but I'm hopeful, and we have a current edition of the voter guide online right now that particularly is relevant mostly for the charter candidates. If any of you are registered to vote in Detroit, there are candidates for the Charter Commission, which would rewrite what's effectively the city constitution. So this is a very important election, and it's very important to know who's who, because most of those people are not everyday names. So on the Detroit Environmental Agenda website, you can see the profiles of what they've responded, how those candidates have responded on our issues.
Let's open it up to questions from the audience. Please, go ahead.
Thank you for sharing your experiences with us. My question is, for Dr. Cardenas, and it's regarding, you shared compelling data about the effectiveness of your programs. How do you encourage compliance with them, whether it's residents or businesses?
Yeah, compliance is such an important issue because if, at least in Mexico, if you don't have these compliance issues, even you can have a very nice legislation or a standard, but if you don't check, no one will comply. So, for instance, for the vehicles, that's a big issue. In order to have this inspection and maintenance program, it is really amazing how much it takes from the government part to implement the program. So you have to check on compliance from those who have the shops, who are actually authorized by the city government to have these shops and actually run the equipment and check on the missions. And then you have to check on the people, on the citizens that go and they don't bribe the technicians in order to get a sticker that is different. And then you have to check on those who actually do the repairs, so they don't actually cheat and they don't do something or they are actually in collaboration with the ones in the shop. And then you have to check and check compliance on our own team, that they are actually doing the same thing. And that actually involves a lot of people, a lot of resources that they shouldn't be waste on those. And I guess as soon as you get people convinced that those measures are important and are actually having impact, then you will not have a lot of surveillance in order to be sure that they are compliant. For industrial sources, you definitely have to have surveillance in order to be sure that they are compliant, that the compliance is actually taking place, because that's another issue. So yes, at least Mexico City has a good system of checking on compliance, but that costs a lot. And ideally, one day we will not need that.
I see that our time is short, and I have had quite an expansive question to ask, but I'll try to kind of bring it down a little bit. I'm Kim Campbell-Boytel. I'm a public health educator and leader at Wayne State University, and compliments to Henry Ford for acknowledging the importance of health systems and the intersection of environment around the health of our city. But particularly for Mr. Williams, we're in the educational business, both of us. I think that a resilient city is built on creating pipelines of developing our youth with the kinds of talents and opportunities that prepare them for leading our city forward too. And while I'm in a university, I know that really that pipeline starts in the Detroit public schools and in the neighborhoods and the youth organizations in the city. I wonder if you can comment at all about how you view that pipeline of developing future leaders and the capacity of our youth in the city.
Well, I'm very glad you brought that up. And actually, I don't mean to keep picking on Layla, but however, Layla was the leader of our youth work in the climate program. And we were blessed to have support to have several years of climate action summits. And we worked with the public schools here in the city and a few other similar agencies in the nearby suburbs. So we were targeting high school age kids there. I know over our 20-some years as an organization, we've really struggled with the capacity to maintain ongoing youth engagement. So it's taken many forms over the years, from youth clubs, you might say that were DWJ youth clubs or something of that nature, to partnering with schools and so forth. Or currently, we're mostly partnering with other organizations that have a more robust structure in place, like EcoWorks, for example, has an ongoing program in many of the schools. And so we work with them to help provide content for what's going on. And I do feel good, though, about, you mentioned that sense of a pipeline, because literally the two key people in the Office of Sustainability now have roots back to Detroit. The director of the Office of Sustainability did his master's internship with DWJ and was primarily deeply involved in our first environmental agenda work and research. And his program manager, Whitney, came up through the ranks, you might say, as one of our high school youth at DWJ, took on an environmental major in college and came back home. And she now works in the Office of Sustainability. So there are other stories of that nature where I feel it is worth the investment, though it's been tough to find the cash to bring that out in a robust and ongoing way.
Who was next? Sorry. Failing. Please go ahead.
I know that a lot of, you mentioned transportation and factories and manufacturing, of course, but I was just curious as to heating and cooling of residences and buildings and what the research shows and how much of a burden that is in terms of the pollutants that we're talking about.
I couldn't quite hear all of your question, but I think you're asking.
My question is, you covered trucks and cars and factories. My question is, how much of buildings contribute to this?
So, great question. When you do go online and find our climate action plan, in the reference material, you'll find some primary research that was done specifically for us. One of them is a greenhouse gas inventory, and that does show that the biggest collective contributor to greenhouse gas emissions in Detroit are buildings and the built environment. And what that means in plain language is the inefficiencies in the building envelope create so much of a drain on energy use. And so it's more or less an indirect cause. It's not like when you're driving your car and the pollution's coming straight out of the car. When you're using your building ineffectively, then you draw on, in our case, burning of coal to create the electricity and the heat. Or in some of the buildings, you're drawing on the burning of trash to create your electricity or your heat. For us, neither is a good scenario. So we do have data on that. It's a great question. It's one of those areas we're hoping the city will literally set goals. Right now, the city does not have goals. And our business and institution group put some goals on the table around greenhouse gas emissions in our report. Thanks.
Next question.
Yeah, my question is mainly for Mr. Williams. So, my name is Kara. Nice to meet you. Thank you for your presentation. I wanted to know if it's particularly difficult or expensive for organizations to pursue recycling for different materials in the city of Detroit. You mentioned that the city doesn't have any clear plan on recycling, and I know I'm personally familiar with an organization that has recycling bins, but the contents of those are emptied into the same bins as the trash and not recycled. So why does the organization do that, and is there anything that we can do?
Well, I'm really glad you brought up the topic. I can't speak to that specific scenario, but what we have going on right now, for example, in this case, every 4 years, the city creates contracts with waste haulers. Years ago, the city owned all the trash trucks and collected its own trash, but more recently, that's done by private companies. So many of the activists in our Solid Waste Alliance are looking to, when the new contracts come up next year, to have requirement that those companies provide recycling, what we call universal recycling, which means everywhere. So currently, our curbside is only for residential. And so we would like to see that expanded to apartments, small businesses, large businesses, hotels, and so forth. And that's something in terms of the cost would be built into the bids that the companies give to the city. And then that typically would be paid either through tax money or sometimes an extra fee or surcharge could be put on the users. But what right now we're missing is the actual structural agreements to make it simple. So if you're in the city, here's one more Googler. Zero Waste Detroit is our primary coalition that's been working on a comprehensive business plan. We did have a great adventure with several leaders to San Francisco about 2 years ago, where we were studying their waste practices where they have mandatory recycling. I would say politically we're not close to that right now, but we do want to at least get the mechanisms in place to make it easy all over town. Thank you for your question.
For 2 more questions, so these gentlemen here, please go ahead.
I'm very interested in how people find their way to their ultimate career and what they're passionate about. And I would ask this of any one of the 3 of you, whether you could share with us whether there was a pivotal point in your life that led you to decide to pursue environmental health, climate, environmental justice. I think that would be really interesting.
Does anyone? Okay. Well, as a nurse, I think we see a lot of patients that, or as healthcare providers, you see a lot of patients that you feel are in the hospital repeatedly for something that probably could be prevented. And so I think specifically just patient experiences, accumulation of patient experiences over the years, and wanting to prevent hospitalization in the first place and seeing what that impact has on people. So really, I think I can't separate my passion for the environment from my passion for caring for humans. And so the combination of the two just kind of actually transformed throughout my career. You're right, people's pathways are very interesting and unique, and they often take many roads, but definitely being compassionate about humans and then also understanding that their environments and the social determinants that they live in impact how healthy they are, and wanting to improve that so that we don't continue to see poor health outcomes has been my pathway. Dr. Cardenas.
Well, I didn't think about it until now, but yeah, I am an engineer by training, so I was supposed to work on processes, and I chose to work on biochemical processes because of my love to science. And then I came out of doing my research in air pollution treatment with biological systems. And yes, the whole thing opens where these pollutants are coming from, who are affecting, and environmental justice is just an issue that comes along a lot of. I was doing research for many years, and then over the last years I'm working in the government part, because it's easy to just do why you are not doing this and this, but once you are in the other side, you see how complex it is, and all the tricks in order to make it happen. So I mean, as a public servant, I think that's a lot of potential, and indeed you have to be aware of not, of course, on the people, but also on the ecosystem. Because air pollution, we're talking about health for people. When we're talking about the environment in general, I mean, all these pollutants are also deposited in the environment, and of course, they have a lot of impacts on all. So I guess that's how I evolve, and I'm totally thrilled, and such an interesting part of being working in the government and realizing that it's much difficult than I ever thought about it.
Well, that's a great question. So, and it's a lead-in to get me to rambling like I usually do, which we don't have time for. So I'll try to compact it. Like, what happened for me is in my mid-30s, I found myself at a crossroads in my life, literally. And this is when I was pulled into what I described earlier, the planning for this People of Color Environmental Leadership Summit back in 1990. And I was on a trip to New Orleans and with the planners and met people, and we were in Cantor Alley. Cantor Alley is 70 miles between Baton Rouge and New Orleans on the Mississippi River, where there's 140 petrochemical plants, 2 per mile for the whole stretch. Like, we have a hard enough time with Marathon Refinery by itself. There, they have more than 100 of those kind of facilities making plastic, gas, fertilizers, everything. And they had at that time the highest cancer rates in the country. But it wasn't so much the intellectual exposure to the information, it was meeting the people and hearing their story and feeling their pain that triggered a spiritual transformation for me in the midst of my own personal crisis of identity. You know, I was able to recognize that my weird and varied experiences in my work career have prepared me to go anywhere and learn anything and communicate with anybody without fear to bring about resolution to these issues. So it's become my spiritual mission. And I'm not going to quit till we win.
Thank you. Sorry, I guess we're out of time for questions, so I apologize, but maybe we can talk privately with the panelists during the break. But thank you, everyone, for a wonderful discussion. Thank you all for your questions. Yes. Thank you. At this time, we'll be taking a 15-minute break, and then panel 2 will begin promptly at 11 now. You want to do 11:15? Maybe a 10-minute break? Okay, 11:10 or 11:15. Thank you.
Hello, everyone. I'd like to welcome you back after the break for the second portion of our program. I'm Dr. Richard Marcolini. I'm with Neighborhood Service Organization, and our acronym is NSO. You'll hear a little bit about NSO in a minute. I'd like to introduce myself first. I'm a Detroit boy, and in fact, my very first job with a paycheck was at this very hospital, and it was as a patient transport. So I would take people in wheelchairs up to their rooms and down from their rooms. I decided at that point that I would prefer to move up the chain a little bit, and so I did study at Wayne State, and was lucky enough to be chosen to go to medical school there. And being a Wayne State med student, I was assigned many rotations in the Detroit Medical Center. So I came to know the population of Detroit, both personally and professionally, from very early in my career. When I finished with medical school, I came just up the street here to the Detroit Psychiatric Institute to train as a psychiatrist. And at that time, it was a state mental hospital, former tuberculosis and polio center, and was repurposed. At that time, that was a Wayne State residency, so just Wayne State all the way. As soon as I finished there, I went down to the medical center and took a position with Wayne State, teaching and training psychiatry residents, and residents in some internal medicine and family practice as well. I also trained as a psychoanalyst during that period at the Michigan Psychoanalytic Institute. I wasn't entirely sure that I wanted to do that additional training, but I was very fascinated with the mind and the mind-body connection. And someone sort of enticed me by asking me the following question: how many psychoanalysts does it take to change a light bulb? Any guesses? It's only one, but the light bulb has to want to change. So after a few years further, I came to Neighborhood Service Organization, NSO, and started working with their populations, and became medical director, and here I am today. So a little bit about NSO. NSO is really a long, long history. Since 1955 has been exactly what it says, an organization that provides services in the community, in the neighborhood. And that's how we feel about where we are. We're in the neighborhood, and we treat people as neighbors. So one of our greatest accomplishments was revitalizing a huge historic building. Not that one, that one. It's called the Bell Building. And those of you who are Detroiters will remember that this building used to have the Yellow Pages fingers on it. So as you would drive north on the Lodge Freeway, the Yellow Pages fingers would appear to walk across the sky as you sort of curved along the freeway. And it had been abandoned by Bell. And our president and CEO, Sheila Clay, had a vision of providing homes for the homeless, providing housing, and providing a permanent home for NSO, because up until that time we had been staying in various places on Woodward, on Grand Circus Park. I remember the time when they came and filmed a Transformers movie, and half of the time we couldn't get into our building. So this has been a fantastic project, aided by many, many, many people in the community. and it's just turned out to be a stunning development. So yes, a small portion of the building are our corporate offices, but a large portion of the building to the right for you is housing for the homeless, permanent housing. So we have about 155 units there, kind of very cool urban loft type spaces, and it is a housing first model. A housing first model means that there's no conditions other than that you're homeless for you to come into the program. So it's full all the time, and we provide very comprehensive services for all of the residents in that building, as well as many other residents. NSO has a huge number of programs, very diverse programs, including treating older people with mental illness, treating general population with mental illness. That's the developmentally disabled at our Life Choices site on Woodward. We have support for young people, training for young people, volunteer opportunities for all of you. It's a wonderful thing. And in addition to this site for homeless, we have really one of Detroit's famous homeless shelters, the Tumani Center. So there it is, right smack in the middle of the Cass Corridor. And the reason we picked this picture, we could have got a fancier one, right? But this is gritty. This is the real thing. There are thousands that take services here of all sorts. So yes, they pop in to warm up, to stay overnight, to get fed. They get case management. They get hooked up with other resources. And in addition, we have a wonderful little clinic that we have here. And that clinic is something of a partnership with Wayne State. Wayne State medical students come there and do rotations in order to understand how to outreach and treat the homeless. And many of the people there have medical conditions that are untreated. And we've expanded this program. It's under our nurse practitioner, Dean Carpenter. We've expanded this program so that there are various Michigan State, University, University of Michigan, many opportunities, as well as the PATH program, which is another thing where we're partnering with many other people. So they actively go out into the community to find the homeless where they are in the streets and begin providing the services and inviting them to the shelter. This is the street medicine program where they'll treat you right where you are. They carry medication samples. And this is our vision for the near future. This is the Clay Center, which will be another homeless shelter where we'll be far better equipped to handle families and provide true shelter. And there will be some housing there as well. So that's a little bit about what NSO is doing. And if you'd like to know more, then just approach me afterwards. So at this time, I would like to welcome our two other speakers today, Dr. Samsuk Bunyabancha and Reverend Faith Fowler. They'll each present, and then we'll have a discussion period. So hold your questions until the discussion period. So now I'd like to introduce Dr. Bunyabancha, who is the Secretary General of the Asian Coalition for Housing Rights, the ACHR, which is a coalition of organizations working on urban poor housing and city development in Asia. She's the former director of the Community Organizations Developmental Institute, CODI, in Thailand. She has worked extensively on urban poor housing development and slum upgrading in Asia for the past 30 years. During her CODI years, she implemented the National Community Upgrading, which has since been implemented in over 300 cities in Thailand, using new community finance and revolving fund mechanisms. She also has experience managing various community-led development processes on rural development, the rural-urban link, and community-led disaster rehabilitation. She has supported community-driven citywide upgrading activities in 215 cities in 19 countries throughout Asia, as well as community development fund activities in over 100 cities. She graduated from the Faculty of Architecture at Chulalongkorn University in Thailand and from the Housing and Urbanization course in Copenhagen, Denmark. She also received an honorary doctorate for her many, many publications, her worldwide work. Really, she's been all over the place and never stops. Fact-finding, visiting, working with so many different people. So now I give you the floor.
Thank you for the introduction. I could hardly speak because the introduction sounds so important, but I'm just very simple. Okay. So I will share with you a very important issue of housing, which I've been working not 30 years, but maybe 40 years. That's the old one. And trying to find new way how the housing development can be solved by the people themselves, because they solve it every day. You see slum here and there. The society never provide them much. People help themselves to find something. So it's a lot of energy, which is so interesting. And if we understand this energy and we support the people to make a proper solution, then it's going to be a new way of housing development. And not only houses, they're going to solve many, many problems, because we center at the people and then let the people be the key actor to do many, many things by themselves, okay? So here is the experience, and of course, you can see the picture. This is from the same area, slums, pure slum, and people change it into something like this. This is the real one that happened in Thailand. So we have the picture of slum squatters in Asia. Some cities have 10%, some have 20%, some have 40% all over. And these are the people, not animals, who have to live like this. And the housing policy, health, whatever, never go to this group of people that properly. So it's the situation of the picture from several cities. And like this, city needs people and labor, but not sufficient affordable housing provide. So people have to house themselves anywhere possible to survive, either legal or illegal, hazard to disaster or flooding, healthy or unhealthy, with limited space to live. So when housing is illegal, everything is illegal. Everything is unhealthy above that illegal setting. So problems of housing which impact on health, okay? This is a platform for health. So if housing is the problem, you name it. These are the kind of health issues related to the people. The poorer they are, the more they're facing these problems. You have the higher mortality rates. There are books saying the poor die young. You have unclean water, you have insecurity near, leading to no improvement or eviction of fire. You have polluted. If Beatrice talking about pollution of the city, people who live in the low-income settlement will face it more than the others. Yeah. You have the unsafe living environment, you have violence, bribery, and crimes, you have sexual problems, young mothers, in the slum communities, you have people will be weak, community will be weak to all forms of disaster, you have stressful life, psychological problems with insecurity, deaths, and threat, and mafias, and all kinds of things like that. You don't have the space for children, you have insufficient small living space and privacy. I'm not going to read all this because you know that these housing problems lead to multiple health problems. Yeah? And in fact, the issue is linked. You have inadequate income, then you have illegal housing built or rented, you have you are out of the political system, you have no protection from the law, you have economic problem. So you put together, if you want to solve the problem, it's not just a health issue, yeah? Or it's not just giving them some money, or giving the people the house. We have to understand how to solve the problem in a multiple manner and solve up to the causes. As much as possible, we can start with whatever issue, but how it leads into a bigger solution. Yeah. So this is what I'm trying to present today. Why housing is important? Housing is important because it's the basic needs of human being. If you don't have it, you have a lot of problems. You don't have your life, you don't have a place to renew your energy, you have a lot of problems. Secure housing provides people and families secure with acceptable status. You are somebody, you are citizen in the society. If the house is not legal, then you are not there. You are not a part of the society, the city or whatever. And being citizen of the city, you entitled for all legitimate city services or not. Insecure housing causes unhealthy living conditions, infrastructure problems, and many other higher expense. So, do these people have house legislation? Normally, no. So this is the key issue here, that do we have secure housing and strong community to function as an immune system and social vaccine to develop and protect all the members? If we have such a system, then it means the member in the community who we protect. Yeah? But if we don't have it, then we're going to have a lot of problems. Then we're talking about the kind of housing in the market by the government or by the private sector. This kind of housing look good, but out of reach, or if the poor people could reach it, they're living in isolation. Individualized housing. I don't know why the concept of housing in the world is turning to be something individualizing people. Yeah? So people live in the city individually in this kind of flats. So it can solve some health problem, but it's not solving all the problems. Integrated development is not there, and people still live in isolation. And the poor people, if they can get access to some of this, which is in most of the cases they cannot. They cannot afford. But if they can, they cannot keep it. Yeah? Or if they stay in this kind of apartment, they stay as individual. They cannot keep with the economic situation and many other things. So this is not the solution for the poor. And from my work, I have learned that if we just provide only this kind of housing or individual housing, which is the predominant system here in America also and many other places, we are not going to solve the problem for the people that properly, except we organize a community in this kind of housing as well. So what I'm trying to present now is a new approach. Instead of looking at the supply side, build something and then sell it to the market and people just being recipient or being buyers, you start with people. Look at people as a solution. So look at people in a different eyes, that these are the poor, these are the people, and they are the solution. So we start from where they are and see what would be the solution they like to do together. as a group. So use the whole housing process to build the people as a unit, as an answer to a new social system and health protection system, in a new strong unit to work together to share with each other and to help each other in several aspects. So people as a subject, people not as recipient. Make people the key subject of making change. The world has changed. Many of our method is conventional method of somebody think for the people and they just follow in whatever some professional tell them to do. Yeah? So let people be the active actor to make change through secure housing and build strong, healthy community and healthy people for the cities. I'm sharing with you experience that I have been working in Thailand. We organized the citywide community-driven upgrading since 2004. We proposed this to the Thai government that there must be a new way of dealing with housing of people in a big way, which is a citywide upgrading. Instead of doing one project here, one project there, and then the housing project cannot keep up with the real change of the city. We should look at the whole city and see how we develop different kinds of housing so the people themselves would become an actor of the process. So this organization that I've been the director and still working on the process until now, we are under the Ministry of Social Development and Human Security, so I'm actually a government all the time, but different kinds of government. And we manage the fund. We receive the money from the government to support the poor, urban poor communities and the network. And government give us the fund and we pass the money to the community organization, okay? We are not going to do things for the people. People have to do it themselves, fix themselves. So in this way, it means people have to be capable. People need to be organized. People need to learn from each other how to do it. If you believe that people build slum everywhere by themselves, but if you do it in a more organized manner, they can do it. But by doing that, they are well equipped with the organization, with the management, with the capacity. And that is becoming a process of development of the people, the poor people in the community by in itself. So the process starts from community and municipality, and you survey all the slum in the city. And with all this community, you try to find whatever on-site upgrading, land sharing, reblocking, whatever. So the physical solution would come from the reality of the survey. And then let the people work with the architects and the engineer, whatever. What should be a solution and how you're going to deal with that, right? So this is the picture of the survey. You spot, the people spot this and you go into the survey. You mean community people. Maybe next picture better. So get the people to make a survey, maybe ward by ward, and then identify where are the communities. So what are we going to do? How are we going to do? What are the numbers of this and that? So open up the space so poor people themselves understand the reason why and they become the actor. Nobody going to do for you. You have to do it yourself, you know? And let them link together as a network with different subgroups, this and that. And then everybody have to do a saving. If they don't have the money, and you only want to receive a grant from somebody as a giveaway, then we become a beggar, okay? But if people want to manage themselves, the project, they need to be able to manage their money. So they have to do a saving. So saving is function as a bank. So we pass the loan to this organization, which is a community bank in a way, and they manage the subsidy as well as the loan. So people have to save. In saving, it means people are able to manage the finance system of the group. If they're able to be active and manage finance as a group, you can add more money into their management system, including finance for housing. And this is the model in which, sorry, the letter is very strange. Cody Fund give to the cooperatives. Like if you give it at 4%, the cooperative give to the subgroup. Subgroup is a social subgroup within a community at 6%. So the organization have 2% margin to deal with the development, slow repayment, management, and the welfare. Yeah? The subgroup deal with the repayment and everything. So this is a model that you pass the money and the subsidy, and they manage whatever development by themselves. And this is the picture showing the architects help the people to plan their own, replan their community in the same area, in the new area, whatever. So make community become the architects. What kind of project you like it to be? What kind of form of community you like it to be? So people understand why they plan it that way, how they're going to plan it. So you use this stage to make the people understand how the new project is supposed to be. And this is the kind of picture, example of the picture. For instance, this is the former slum. It look like this. So the architect and the people plan it, something like that, like reblocking. So you move the house. You move the house. The green is the former location. The brown is a new one. So after 2 years, it look like this. No slum. I always said, so people themselves, they're not slum. Because this is the same group of people. You change from this to this, people can change. But it's the system which is the slum. The system never offers people this possible way to do, to organize, to find the solution by themselves. They can do it. People can do it. But sometimes when we think that people cannot do it, it needs to be trained. People need to be this and that, learn this, learn that, and they have to follow the rules that we impose them. But if we slow down a little bit, let them talk, let them find a way, they don't have a problem. So this is the same community that changed, and you cannot see what slum there. This is one big project where we reconstruct the whole canal, where they encroach the canal because of the flood problem. So you reconstruct the whole thing from this situation to this situation. And once you change it, all the environment change. You have more open space. People manage it as a group. They manage the repayment. They manage the maintenance. They manage many things, and I'm going to tell you more about that. See? This is all the reconstruction of the canal. This is one very big project in Bangkok, and this is the former picture. See? And block by block, they manage by themselves. And not only physical stuff, it includes everything. This is a reconstruction project. This is a former slum. So you break all that. You reconstruct all that into a plan like this and like this. Yeah? So you can imagine the health condition changed tremendously through this working process. Or sometimes you need to move this for community into a possible land here because there are roads, there are whatever redevelopment. So you move them to the land available. Or if this one face eviction and you found the land here, you move the people there and like that. So slum can move a little bit. It doesn't matter as long as there's a clear solution and they understand what to do. This is another project where it's a former community. Once they move it, you give people the subsidy and the loan, and they reconstruct it. And one unit like this costs about 10,000 US dollar. 10,000, similar to your one month salary maybe. And this is the renter, scatter renter in the whole ward area. You link them together into a co-op, and they purchase a land, close to that, and they build this housing. This housing is cheaper than the rent they paid before. They pay for land, they pay for housing. The poor can do the housing much cheaper than anybody. Okay? They're not following the market. This is the way they do. So you use the housing construction process as a way in which people work together. So once they have to work together, they learn how their neighbors, how the other members are like, yeah? And it's the way to build a community system. And then you have a process where people themselves can clean up the canal. Municipality saying, oh, this is their job, whatever, but they rarely come anyway. But people are the ones who live closely to the canal. They can clean up, they can make the treatment in which the bad objects are not going to the canal. You can let the youth in the community to have the conscience of the canal, and they could keep up the clean water. You can have because they have the community development fund, funding become a bank. So it become a welfare system also from the interest rate. For everybody, community can check how many elderly people inside the community. And then you can develop a lot of activity for the elderly people, for the children, for income generation. Some organization purchase the rice field so you can secure your food. Huh? You deal with disaster much faster because you are more organized and you have your funding. You can also link all the children in the community together. You can, we have a program for the community garden to grow clean organic food, vegetables. So it means anybody in the community can help in the planting as well as can take the vegetable from the garden if they don't have the money at all. And this is the elderly program. So you have a club, you have activity, everybody is a part of different things. So at the end you have collective land, you have a community saving fund acting as community bank, you have welfare activity, you have scholarship, you have children, youth, elderly, care for the sick and disadvantaged people, you have active link with the city through the community network and local organization, you have collective management, you have active citizen. So it's a process of changing the whole unit of the people into a new system. So housing itself, if we look at it, is not just a physical shells or physical thing, but we link people together. We invite people to live in one housing project, but in most of the case, we just allocated them a unit and they don't know each other. There is no social system to link the people into a social unit. And this is what is so important, especially for the poor people. Poor people, once they link it into a social unit, they can deal with all kinds of problems in a very, very cheap cost and very efficiently. Yeah. So this is a system that once you have a network, you could link with the government. Now, proposal to different kinds of policy is there. Yeah. So you are a good friend to the government, you are a good friend to the police, you are a good friend to the professor, this and that. And so you invite them to help you. Yeah? You invite the inauguration of the community center, ask the mayor to inaugurate, and then you talk to him about the women, the children, and many other issues at the same time. So make a political change. Once the people link together into a citywide upgrading, you have a big number of votes. So you can be the one who propose to the system what it should be, but do it in a diplomatic manner. Yeah? So in this way, people are shifting from the poor power group into a negotiation partner. And in this way, you could change the political system at the city level, if you do it well. Yeah? if we do all this health development without looking at a change in the policy at the city level or higher level, we are dealing only with the symptoms. Huh? The cause we cannot deal with, except we deal with the policy, and then we are occupying the implementation process of that policy as well, as much as possible. Yeah? So we developed about in 73 out of 77 provinces, we grant the loan something. I'm not going to read about that, but we get the repayment of 97%, okay? So if community get together, you give a loan to one community, it's only one loan, but they deal with 100 family with 2% margin. So in this way, they repay to us as a group. By repaying to us, they have to manage the finance among the members. Yeah? So you will receive mostly 100% repayment because they are all at stake. Yeah? Community will know how to get the repayment back among themselves. But if we deal with each individual, you have to go into the community and try to check why these families are not paying to the government or not paying to us. The neighbor will try to give you the wrong information because they want to help the neighbor. But in this way, if the whole community have to be responsible for the whole loan together, they would find a way. If there is a problem with this family, how to find a way, because they need to collect 100% repayment in order to be able to repay to the organization. And this is the pro-poor urban development resilient city that you have the poor and their settlement included in the governance, you have the law to protect them, you support informal enterprise, you have a lower transport and eviction problems and make legal house affordable, so poverty much reduced, income increase, and better health condition. Just a few pictures, sorry, it may be a little more time, but a few pictures to show that we expand this process to Asia. We make the program called the ACA program, in which we support the citywide upgrading to the cities in Asia, and we're able to support up to 19 countries from Afghanistan here to Mongolia to Fiji. Yeah. And these are the cities. The model of support is just about $60,000 US per one city. Not a lot of money at all, but citywide upgrading. Because we want to outreach to find a way that poor people in this city are being a part of the active process to solve poverty and to find solution for their housing at a citywide scale. How to do that? And this is what we think this is a minimum amount of money. This 60,000 is good for a small project, about 5 projects in one city. One first housing project, about 40,000. City development coordination and exchange visit, whatever, put together allows 60,000. So each city will start with a survey like this. People will look at the map of the city and where are the slum community, and then you make a number of all the poor people settlements. And then with the small project support, they build whatever possible, whatever thing they think is important, about $2,000, $3,000, they have to agree among themselves. So people, if you look at the whole city, it's like poor people in the whole city are now moving, are now really in an active dynamics of making change. Yeah? So the city are really worried, some cities are feeling worried that people are now uncontrolled. Now they want to do things, they want to move things, but you lead the city development this way. And by doing that, they organize as a network, they have the information, and they have a plan. So you start negotiate with the city for more possible development. You can see different kind of development. These are all by the people themselves. So you use project to activate people. So people change from the passive recipient, passive mode, into an active mode, and to be a leading force instead of following group of people. So you have confidence, you believe in yourself, you are now active, you think that you can do things. Okay? This is in Cambodia, from this kind of situation, in one main street, you know. The spirit, the whole thing of the people, the children have been changed so much. And then it leads to the kind of housing development. This is in Myanmar, this is in Vietnam, this is in Fiji. We are able to support up to 146 housing projects, where all these cities never start anything. People live in squatters, facing evictions and so on. So you start with the first housing project, and in the period of 5 years, we are able to support up to 146 housing projects. So it's just a quick look of different kinds of housing in Myanmar, in Tibet, in Nepal, in Mongolia, in Cambodia, in Bangladesh. Just a picture to show that it's not only houses, but it's the process of building the people. So when people want to develop a housing project, and they have to plan themselves, they have to make a model, and they are the one who adjust where it is, and they need a discussion why you put the house like that, why you have to put the street like this, why that. It's the way that people start understanding what housing project means and how they want to group themselves, why they have to plan it that way. They alert on what would be the situation they want it to be in the new housing project. People don't know what 1 meter, 2 meter mean. So you have to really let them, sometimes you have to draw it on the floor, what the toilet with this dimension mean, whatever. There's few pictures to show, finish now. The poor like this, and then they redevelop like that. This is not 40,000, but 40,000 is a part of a small fund that lead into this change. This is in Nepal. You see the picture of a lot of people. This is something we want to build. This is the result. This is not the main target. But if you do it well, the people process, you do it well, you have a very beautiful house in a very cheap price. Okay? This is in Afghanistan, where you allow the people to link together as a network and a saving group, and by creating space for people to do activity, you are making a new move, a new positive move. What we like to lead to is the new politic of cooperation and building local partnership for broader participatory city development, changing, upgrading political relationship and collaborations. It has to come to this point. Then many other issues which relate to policy and bigger picture, it would relate to a small picture of where people are, how people are. So this is the end. Sorry, it's a little long. Thank you.
Thank you very much. That's delightful to hear about your amazing work, and she came all the way from Thailand to present that for us. I'd like to introduce our next speaker now, Reverend Faith Fowler. She is the senior pastor of Cass Community United Methodist Church and executive director of Cass Community Social Services, which is a Detroit nonprofit agency which responds to poverty with programs for food, health care, housing, and employment. She's held those roles since 1994. In addition, she served as board member for the Cass Corridor Neighborhood Development Corporation, an advisory board member of the Detroit Area on Aging, as well as a board member and trustee for the General Board of Church and Society. From 1986 to 1984, she was the pastor of William S. Ford Memorial United Methodist Church in Detroit. From 83 to 86, she worked with the Catholic chaplaincy team at Walpole Maximum Security Prison in Massachusetts. She has received a Master of Divinity from Boston University School of Theology, a Master of Public Administration from the University of Michigan, Dearborn, and there she continues to teach as an adjunct professor. She's received many, many awards and acknowledgments for her work throughout the many years, including a McGregor Fellowship and a Forbes Impact Award. She is always running from one place to another, and apparently at least 4 times ran into the Boston Marathon and just decided to finish it. I'd like you to welcome you now to the podium.
Thank you so much. It's an honor to be here with you, Richard, and Samsuk, I hope I pronounced that right. What impressive work you're doing. So thank you for sharing with us. I'm not going to go into much about me or even my organization because Richard did that. I'm going to go right into the presentation. Oh, good. So what you'll see in this presentation is a project we started in 2016 called Tiny Houses Detroit, Tiny Homes Detroit. Many of the photos in the presentation are actually homes we've either built or are going to build. So let's get right at it. We purchased 25 lots from the city of Detroit for $15,000. How'd we do? Come on, look out Dan Gilbert. That's big, right? With the notion that we build 25 houses between 250 and 400 square feet, so roughly the size of your 2-car garage. Every single house we decided would be different inside and outside on purpose. Why? Because poor people tend to live in housing that's nondescript and ugly. I like to call it Pepto-Bismol shade of something. Right? So we wanted people to have pride in where they lived and be able to describe where they lived and to have the places be as distinct and different as they are. We're putting houses where, oh no, how'd it get there? We're putting houses where houses used to be, meaning it's been a residential area since 1916, 17, 18. The houses came down in the 60s, 70s, and 80s, and since we're putting a house where a house was, we didn't need any code changes or variations to build there. Also, just so you know, the city of Detroit has no minimum building requirement. So we could have built smaller. We didn't want to. By definition, a tiny house is anything below 1,000 square feet. We built on vacant land. There you go, good. Occasionally people criticize us that we're not rehabbing. In fact, we have rehabbed about 12 different buildings, many of them over 30-unit apartment buildings, so we're not averse to building, but which building would you rehab? Nothing there. Okay, good. The other thing I would point out is that we're building on the edge of our campus. So we have 2.5, 3 blocks up there that we purchased for such a good price. It means that the people living in the tiny homes will be in close proximity to the rest of the campus. I know campus seems a little bit much for us. We're a small nonprofit. But we have lots of blocks that are contiguous so that people can walk to food, a job, a counselor. Stop that. Is this thing possessed or what? A bike, a doctor. We have 2 free medical clinics, which is really important because if you're poor in the city, you probably don't own a car. You can't afford the car, you can't afford the insurance, you can't afford the maintenance. So to have a pedestrian place for poor people is really a great thing. There we go. Occasionally somebody says to me, oh, Reverend Fowler, I've heard about this. Another organization here in the United States is doing something just like that. Well, they're not. They're building tiny house villages, which are good. I'm not here to criticize them, but it's something different by its mission and purpose. They're building an arrangement that would substitute for a shelter, right? Some people don't want to come into shelters. There's good reasons for that. Shelters aren't perfect. So they are actually targeting people living on the streets and getting them to move into tiny houses in what are called tiny house village configurations that's based after the old tent city design. So there's a ring of small houses. Actually, most are tiny bedrooms rather than tiny houses. I don't know how to get this to stop doing it, but stay with me. So So they have a bedroom, and then they have community space where they go to for eating, showers, laundry, TV, all that stuff. Some of them don't even have electricity, water, or heat. So to have those sorts of amenities, if you will, they have to go to the community building. This actually was the first tiny house village to use government money. Consequently, they built fairly good houses, I think. But again, it's just a bed, a sink, and a toilet, and you're literally going to another building for everything else. We had a different proposition. So much like NSO and Rescue Ministries and Salvation Army, we work with homeless people, 300 people a night, men, women, and children. Last year, over 500 children, just so you know. So if you have an image of a middle-aged man who's homeless, you're not quite right anymore. But anyway, after 24 years of being at CAS, what I've discovered, is that we can truly help people who are ready for help. You know, you want to get clean and sober? Okay. You need to get on your medication for mental health issues? Okay. You need a job? Good. You need an apartment? Fine. You need a car? Good. You need to get back with your family? We can help you do all those things if you're ready. But then you move out and on your own, and like a boomerang, you come back. 6 months, 8 months, a year, you're coming back. And what happens is that people hit some sort of crisis in their life, right? They get sick. They don't have insurance. All of a sudden, they're struggling. Somebody in their family dies, their husband, their wife, their kids. It's violence. It's not. They're stuck in grief. They never get over it. Again, they're poor. They lose their job because their car breaks down and they can't fix it. All of a sudden, they're put out on the street. And so we began thinking, is there a way not only to help people have residential stability, but to have economic mobility, meaning to have an asset? To have something that would serve, like most of us use our families. When we're in trouble, you call somebody you're related to, usually by blood, but maybe not, and you say, can you help? Poor people usually are related to other poor people who can't help. And so we began to look at tiny homes as the way for poor people to build wealth. And that's huge in a city like Detroit, because the last census says a third of the households, not people, a third of the households in the city of Detroit live on $15,000 a year or less. That says it all. That it just takes one thing going wrong for the domino effect to cause you to spiral. So we came up with this idea called rent then own, which is different than rent to own, because rent to own usually means predatory lending, right? Ours is a program where you rent based on the square footage. If you're in the smallest house, you pay $250 a month. It's $1 a foot. The largest house would be $400 a month, and your math is good enough to figure out in between, which is roughly half of what you'd pay anywhere else. But then you have to agree to the program, because in 7 years, you're going to own that house. You don't buy it. You don't pay for it. We've raised the money up front. What's really been fun in the last 2 years is to find out how generous people here in Detroit, metropolitan Detroit, are. Actually, people from around the world are. Because we started with nothing. We started with this PowerPoint. And then in 2 years, we raised $2 million. For a small nonprofit, that's huge. So here's the program. In addition to paying rent, you have to meet once a month, much like the good doctor said. You want to build community, right? So once a month you meet with your neighbors who are tiny home owners as well, or going to be, and you talk about what's it take to manage the house. Do you remember your first house? How many times did you call your parents to figure out how to fix, the chain on the toilet, or to clean the gutters, or the filters, or all that stuff that all of a sudden you're responsible for and you never had to do before? So they meet together, and they talk about those issues. They school each other, if you will. The other thing they do is they meet with a financial coach. Everybody gets their own financial coach, because everybody, although they make between $7,500 and $15,000, more like $12,000 a year, they're all in a different place. So the coach, who's a volunteer from the banking credit union industry here in Detroit, meets with somebody privately and says, do you have debt? If you have debt, we're going to deal with that first. Do you have a budget? Oh, you don't have a budget? We'll make a budget. Do you have a savings account? Do you have a checking account? All of that's pretty standard. Almost every social service agency does most of that. But then the coach says, can you earn more money? Now, that may sound like an odd question to you, especially if you haven't lived in affordable housing. If you live in affordable housing and you make more money, your rent goes up. If you live in affordable housing and you make too much more money, they tell you to get out. Which teaches people either not to be ambitious or to lie about having more money. Because who doesn't want more money? Raise your hand. That's what I thought. So the coach says, if you earn more money, you get to keep it. It's yours. Because your rent's based on your square footage. So can you do nails? Can you do hair? Can you babysit? Can you walk a dog? Can you rake leaves or shovel snow? It doesn't have to be a 40-hour a week at CompuWare. I mean, anything. If you're living on $7,000 a year, to have an extra $600 is a big thing. So once they do that, once they have the little bit of extra cash, the coach comes back and says, have you ever had money make money for you? And of course they haven't. And so the coach suggests, well, what if we take a small part of your money, it's your money, you can decide, and you buy a savings bond? Or you go to your financial institution and you get a CD. Or what if we pick out from the stock market something that's relatively safe so that they begin to see their money can earn interest, and eventually they can see their money start to compound. And when they own the house and their refrigerator breaks down, they have a rainy day fund that they didn't have when they moved in. The last thing they have to do is much like Habitat is sweat equity. They volunteer 8 hours a month, every month for 7 years. But they don't do it with the builders, the volunteers. They do it in the community. Again, you want the community to know the people, and you want the people to know the community. Not just the tiny house community, but the larger community, so that they get seen as the asset, and so that they really put down roots. So they do things like CB Patrol, or the Trunk or Treat, or the Christmas giveaway, all kinds of things that they can get involved in the larger neighborhood. Now, who are the houses for? At least half of them are for people who are formerly homeless and or formerly incarcerated, because their chance at owning a home is next to none. Another good chunk of the residents are senior citizens who are low income, by our definition, $7,000 through $12,000 a year. And the last bunch of people are young adults who have aged out of foster care, because they too mostly lack the security in their family to help them get started in adult life. And so we did it that way on purpose, so that it was diversity in the neighborhood. Age, education, experience, color, religion. I think you live in a city because you like diversity. If you didn't like diversity, you should probably live somewhere else, right? And so in the first 7 residents, we had ages 24 to 74. We had 3 women, the rest men, 1 dog. Oops. We had 6 out of 7 people of color. Their average monthly income was $988 a month, so less than $12,000 a year. Now I want you to put your head around that for a minute. Here's a picture of a renter. So if you're homeless and moving into a home that potentially you're going to own, everything changes the day you get the key. It doesn't change in 7 years. It changes that first day. Because if you've come from a shelter or an institution, you have no control over anything. You don't decide when the lights go on or off. You don't decide what the temperature is in the room. You don't decide when you're going to eat, what you're going to eat, whether or not you get a snack. You don't decide what's on the TV. There's 80 people in the room. Good luck. You don't determine when you get to shower, when you get to smoke, when you get to do laundry. That's imposed on you. You don't get to decide whether or not you have company. What are you going to do, set them on your shelter bed? You certainly don't get to decide whether you have somebody spend the night, which seems wrong for adults. So the day they move in, the day they get the key, they get a door, they get autonomy, they get dignity, they get privacy as well as community. And all of that changes. Lights on or off, who cares? It's your house. Music loud, who cares? Temperature, cold, hot, it's your house. Some of them have it at 90 degrees. Wouldn't be for me, but that's how they like it. You want to eat at midnight? You want to eat junk food? You want to eat extra? You want to skip a meal? It's your refrigerator. You want company to come for your birthday or Thanksgiving or Christmas or some other holiday? Great. How about you're feeling like Luther Vandross tonight and you want somebody to spend the night? I am not your pastor. Go on. You want a dog, a cat, a goldfish, a T-Rex? Actually, I don't like cats, so I'm not sure why this is even in the slideshow. So it changes right away. We're building the houses with a professional builder who does the foundation, the walls, the roof, the electrical, and plumbing, because all those things require licenses and permits, and of course we're building to the universal building standards. We're not trying to get around or find a loophole. We want them to be sound, safe, healthy homes. We started by doing environmental testing on the soil, which some organizations don't do and I think is wrong. Then we use volunteers to do everything else. Drywall, taping, sanding, painting, flooring, cabinets, countertops, landscaping, because it saves us a ton of money, although it slows us down. Those people become our ambassadors and tell the story all over, and they help us network. So this is always my question. Do you like the Victorian, or do you like the recycle house better? Well, don't be shy. So let me tell you this story. This house, actually, we built up in Lansing with Habitat for Humanity, Michigan, and Mishta, and brought it back down and re-put it in place. It's barnwood from here in Michigan. This house we found online when we were looking for really cool, good-looking houses, and then we discovered there were no architectural plans for it. Dang it. Like the old Hollywood sets, you know, there's something up front and just posts behind. So I found an architect in Ann Arbor through Rotary and showed him the picture and said, can you draw me a house? And he did. And he gave it to us so we can sell it to other people, right, who want to build a Victorian. The other thing is that people bring us materials once they volunteer and see how little it takes to do a tiny house. If you have extra paint or extra tile or extra whatever. Actually, my very first parlor meeting was in Grosse Pointe. You go and you tell the story, and at the end of the story, you shake down the people to give money, right? And this little old lady lifts her hand and says that she's redoing her kitchen. Could we use her old granite countertops? I said, hell, I don't have granite countertops. And then we picked them up. Her old granite countertops were enough to do 3 houses, right? So it kept it out of the landfill. It repurposed. She got a tax write-off. The residents got granite countertops, and we didn't have to pay for them. How cool is that? Every house is on a foundation slab on grade. We don't do basements. The thing about houses that came down in the city in the 60s, 70s, and 80s is they raised them and they buried them in place. So underneath the ground, you have concrete and metal and glass and big obstacles to scooping out the dirt. And it would be very expensive unless I toyed with the idea of telling somebody Jimmy Hoffa was buried there. But yeah, that was a good laugh. Every house comes with a front porch, back porch, or deck of some sort to increase the living space. Every house comes with a washer-dryer combo unit like you'd find in Europe. A stove, refrigerator, microwave. We do things, there's no dishwasher because you're trying to increase the floor space. So even with the hot water tank, there is none. It's hot water on demand because it's on the wall. There's no furnace. It's through the wall like a P-TECH unit. Every house comes completely furnished and designed by an interior decorator. They can say, I want it all. I don't want any. I want just some of it. There's no charge, and they get to keep it. Landscaping is good for Michigan, so you're not having to work so hard at keeping it up. And Greening of Detroit and the Herb Foundation are helping us with rain barrels. Every house comes with a security system so the things and the people are safe. We got a really good deal from a man. I questioned him. And so our owner rep wrote him a letter and said, how come your quote is coming in so low? And he wrote back, I love this. Stacy, 20 years ago I was a drug addict. And somebody helped me. And now it's my turn to help somebody else. This whole project has been like a barn raising. I'm here to tell you, no matter where you are politically, you know these last 2 years have been horrendous for us. And you forget, with all the name calling and judging and tribalism, you forget that there are more good people than there are bad people. and you forget that people who have taken advantage of a second chance are usually the best people on the planet. So I love that story, and I love that man. It gives me hope. We started in 2016. We built the first house. We didn't move anybody in until 2017 because way too many people were coming, peering in the windows, taking selfies. We were afraid somebody would be scared to death. Stop it. We built 6 last year, so we're up to 7. We built 6 this year. We're up to 13. We've just started 6 more that will be done early next year, and potentially we'll have the 25 done by the end of next year, and then we'll start some for families that will be slightly larger because of the need for bedrooms for kids. Here we go. We've had all kinds of media attention, 75 million views, which means we've heard from, let me go through, India, Italy, Canada, Mexico, Peru, Australia, Japan, Germany, the UK, South Africa, Ghana, Liberia, and Bangladesh that I can remember. The house itself, just by its size, is better in terms of resources to build it and to operate it. There is a book about it if you're interested. It's $20. You won't hurt my feelings if you don't buy one. We have solar there that we introduced because the whole house is solar. We made generators at first, and then when Maria hit Puerto Rico, we took 50 to Puerto Rico and powered them up. When we came back, we heard from other places, including Liberia and Ghana. We're going to Liberia next year to power up a school. And then when we hit the really bad weather last year, we put solar arrays at each house so that in a normal month, you'll pay $8. So it's good for the planet, it's good for poor people, it's good for the city, it's repopulating a neighborhood, it's doing it in a sustainable way, in a healthy way, that people, who moved in with everything they own in a bag, in 7 years will have the opportunity, will own a house worth $40,000 or $50,000. So now they have, a collateral, now they have something they can sell, now they have something they can leave in their family for generational poverty, and we're really excited about it. I went too long. Bye.
Thank you, Reverend Fowler. That is really amazing, innovative work, and much of it taking place in our neighborhood, just a couple minutes away. So now we're going to open up for the discussion period. If you have any questions or comments, make your way to one of the microphones. Please introduce yourself.
Sure. My name is Julie Gleason-Comstock. I'm with Wayne State University, the public health program there. I wanted to thank you, Mr. Marcolini, for talking a little bit about Street Medicine, Detroit School of Medicine. It's been very active in that. I had two questions for Reverend Fowler. The Cass Community Services has been able to take open space in Detroit and also make that space safe space. What do you think the potential is for tiny houses or tiny homes in urban areas that might not have as much open space available? Secondly, I have very fond memories of coming over to Cass Community Services and the food vocational program that you had, and some of the chefs that were providing food. I wondered if that vocational program was still in place and if there was some synergy with the little houses, and that food is such an important element in our home environments. Thank you.
So I think the model would work anywhere, quite frankly. I think it would be appropriate in rural areas where they're used to barn raising. I think it would be appropriate in suburban areas where you have a lot here or there. Clearly, Detroit is the land of opportunity in terms of inexpensive land and available land. Because of who we were trying to serve, it made sense for them to be a part of our campus. But it isn't, it could be for any young adults. It could be for any senior citizens. There's only one step in, so building a ramp is next. Even I could do it. Making it ADA compliant is very easy. So I think it has many, many applications, and we've had people come from all over the country to try and replicate parts of it or all of it elsewhere, so I know it will be. In terms of the food, we no longer have that government grant, but we do in our green industries. We're recycling illegally dumped tires and paper and cardboard and glass and wood out of houses. And we currently have 85 people working in green industries. It's all supported by sales of the items, and they too are doing our solar work here and internationally once a year.
Thank you.
Hi, thanks. Alex Plum from the Global Health Initiative here at Henry Ford Health System. Fantastic panel and wonderful examples. You're talking to a bunch of healthcare experts. You're talking to people, and especially in healthcare, who often feel, and I'll say this as a person skilled in public health, that we're the experts and we have the answers. And yet what I've heard from you today is a really wonderful set of examples where you've given people agency and autonomy, and you've trusted them that they know, in fact, what they need, and they know what's good for them. And that's, I think, hard for us in healthcare to be honest with ourselves about. So I wondered if you could just talk for a minute about the challenge and the struggle sometimes and what it means to trust someone, even though what you think, based on your experience, it maybe isn't best or it isn't good, and what that trust and how giving that trust has led to some wins for you in both of your work, because I think it's a lesson we need to hear.
Okay. Of all the housing development actor, government, NGO, professional, community people are the most passionate. They want change. Nobody wants to be illegal. Nobody wants to be a low class forever. They want change. Yeah, okay? So if this is a basic thing in all the informal group of people, of course, the informal group of people have different fractions. If we focus on some fraction that this is gambler, this sometimes drinks and so on. So we sort of try to look at them as a problematic group one way or the other. But if we try to look into the energy and the way they want to change and link them up and they balance themselves, find a way that people balance themselves and look forward. Yeah, the way in which they're very passionate to change their life for their children, for themselves, and the way in which they're able to balance and they start looking forward and make plans, start moving into what would be a possible thing to do, what are the possible way to develop this and that, we have to learn this and that. They start changing. They have the energy to change. Yeah? We should not look into too much personal, kind of behavior and try to see what are the positive energy that exists and use the momentum of the positive energy to link them up into a unit of change. And they help each other. There are drug sellers, of course, in the community. There are people who benefit from the others. But if they start moving into the direction together, the problematic condition will be minimized. And by working in the different activity like saving, like surveying, like checking what are the land situation and then how to negotiate, it's sort of a more forward-looking direction. This is another thing. The other thing is to find a way that women become an active actor. Women are the key to success. Yeah, okay. Men spending the money, women collect the money. Yeah? Women know all kinds of information in the community. Everything, every gossip, every secret, whatever. Women know all. Yeah? I don't mean women should develop in the secret thing, no. But it means these are the actors who have all kinds of information. Yeah? So you link them up, make women more active and decision maker, and little by little come into a new balance of the development, and they can go. That's not a problem at all.
Reverend, do you want to address that? Go ahead. That was addressed to both of you.
Well, I guess the issue is trust, and that's an issue that's closely related to faith. And I was hoping the Reverend would address that. That's her name and it's her business. But she's graciously asked me to say something about it, and I was specifically asked about the street medicine. So I think that's the segue, and that is that we reach out to people, and we hope they'll take our hand. Once they do that, they come to know you. Sometimes we have to do this over weeks and months and years. These vans have been going out for years. Some of our folks actually know where people live. They live under that underpass. If you need to see Joe, that's where he is. And so eventually they establish some trust, and even the people who are most reluctant because of the way life has treated them do give you an opportunity, and that's the blessing. We have another question?
Yes. There we go. My name is Blake Sanford. I am an MD, MPH student at Wayne State University, and I want to thank all of you for your wonderful presentations and the work you're doing. So you highlighted a lot on the theory behind these programs, but I was hoping maybe you could share some personal anecdotes or stories from the residents and how they've been impacted.
So because we had so much social media attention, it meant many people were commenting very positively about what we were doing, and then others were reaching negative conclusions, often because the videos that were out there weren't accurate. So folks were saying things like, oh, why would you do it in Detroit, and why would you do it with homeless, and why would you do it with poor, and just they're going to be crack houses, and they're going to destroy them, and I mean, all sorts of unfounded conclusions from people who probably have never been to Detroit or know anybody who's homeless, or on and on. So the first year has been just tremendous of the residents. A couple stories, and then I'll be quiet. One is we took a man in to see a house, and on the way in he looked rather glum, non-excited by it, and he came out grinning ear to ear, and I said to him, what happened in there? Because we trusted him to go in and look around on his own and come out. And he said, it's got a bedroom. Well, that was important to him because he had spent 20 years in prison and had no privacy at all, right? So that kind of thing. The other story that just will stay stamped in my memory until the day I die is, do you know what day October 1st was last year? What day of the week was that, October 1st? Nope. It was a what, Habitat Day? Was it? Oh, well, maybe in Thailand, but here, okay. Here it was a Sunday. And the reason I remember it was a Sunday is because Sundays I work, I have another job, right? I'm busy writing a sermon, telling the choir to sing one more while I finish my sermon. I'm a procrastinator. And the phone started ringing and ringing and ringing and ringing and ringing and ringing, and I just couldn't avoid it. What do you want? Right before going in to worship God. And it was Carolyn, one of the seniors living in one of the tiny homes, and she said to me, Reverend Fowler, the World Building is locked. That's our administrative building on Rosa Parks, and I can't pay my rent, and I don't want to lose my home. And that Sunday morning, I got calls from 4 of the 7 residents saying the same thing. So what that said to me, I guess I didn't realize it before, is what this home means to them and how hard they'll fight to keep it up. It's funny to watch them over the summer. They were sort of unofficially competing about who has the prettiest flowers. I can't wait for Christmas to see the lights because it's just going to be wild out there. But truly the sense of joy and aspiration that I feel from them that often I don't feel in our homeless programs or our work with poor people, that they know that their life is going to change, that they've been given an opportunity. I liken it to the game Chutes and Ladders. Did you play that as a kid? You fall down the chute and you go backwards, or you climb up a ladder and you go forward. But if you're poor, you only have chutes. You only go backwards. And our job, I believe, as an agency is to drop a ladder, or 2 or 10. and then it's up to the people to scale it and move ahead. And that is what I believe this program does. Much like our employment program, it gives the chance for people who are ready to have an entirely different life. And it's made them very happy, and almost as happy as it's made me.
You're still at the mic, so is there something more that you'd like to...
Oh, the question was for everyone. Oh, yes, I was just hoping to hear if you had any stories from the residents that live in the new housing developments.
There's so many of them, but not today. Today my head function only half. Yeah.
That's okay.
Feeling a little sleepy because of the jet lag. Yeah.
Okay. Thank you all.
Yeah, maybe we can have lunch together. And
Sounds good.
Hi, I'm Priya from the University of Michigan School of Public Health. I was wondering, so all of these programs have been in place for at least a couple of years. What issues have you faced, I guess, along the process, and just how have you combated them or plan on combating them?
There we go, is that contractors lie. They lie about how much things are going to cost, and they lie about how long it's going to take. So that's been our biggest frustration, is trying to get things done on a deadline, because in the first month we took 122 applications for 25 houses. In the next 6 months we had 900. So we have 1,000 people who want to live in 25 houses, and I just can't get them done quick enough to move on to the next phase.
It's the people work. So when people is the key actor, things are not highly smooth in itself. Yeah, because in developing everything is a process of change in itself. We are not just looking at the result, like the building finish, but how the transformation of the group process and way of thinking and relationship between the people and the other would be changed also. So this whole development process is not that very easy. Yeah? So it takes time. But I don't think it's a serious problem. For Thailand, now we move the process to the rural as well. And my trouble is that it's not fast enough. I think that we need a lot more units and bigger development, city by city, like that, rural by rural. Yeah. It's not fast enough for me. At the international level, what we have the problem now is the financial problem. We need the funding to support this kind of change that would trigger the direction of change in many, many countries, because up till now, so many countries don't have the policy, don't have the funding, don't have the institution, and no direction. So we should use the citywide process to influence change by people in different cities in Asia. But we need a sort of a solid financial support to intervene this big change by people. So that is not so easy at the international level.
Well, thank you. I think we could go on and on with our discussion, but we have lunch waiting. But before that, I'd like to introduce our final speaker. Mr. Chip Amo is the Director of Sustainability for Henry Ford Health System. In his role, he oversees the system's environmental efforts to improve the health of employees, patients, and the community. He assumed the position in June 2018 after serving over 7 years as the Assistant Director of Government Affairs for Henry Ford Health System. Prior to joining the system, Chip worked as Legislative Counsel for the American Medical Association and as Assistant Director of Federal Affairs for the American Society of Anesthesiologists in Washington, D.C. He also worked for local and regional economic developmental agencies in Pittsburgh. Chip holds a BA and a BS in political science and consumer affairs from the University of Rhode Island, and a law degree and Master of Public Administration with a concentration in urban and regional affairs from the University of Pittsburgh. He's a Michigan native, an active triathlete, and believes in taking a health in all policies approach to improving health and well-being of our state and its unique natural resources. He is active in the community, currently serves as Secretary of the Board of Directors for Neighborhood Service Organization and on the Executive Board for the Detroit Greenways Coalition. Let's welcome Chip Amo.
Thank you so much. So I get the distinction of standing between you and lunch, so I apologize for that. So I was going to do the wrap-up first, but after hearing everything, I thought I would just talk a little bit. I'm going to switch things around. I'm going to talk a little bit about our program here and what sustainability is, here, and what that means for Henry Ford Health System. Amy already did a wonderful job of talking about Allegiance's efforts, but as mentioned, I am about 4 months into this job, so it's a pretty big task for the size organization that we are to be tackling the sustainability. I always say, people ask, how do you do the job? I kind of liken it to the analogy of how do you eat an elephant one bite at a time? But the problem is, in this case, our elephant is running. There are a lot of things happening in the system right now, so trying to keep up and eat that elephant is going to be a challenge. So I'm just going to start really kind of with the case for hospital sustainability. And I was reading an article and I came across this comparison here in this quote, and I thought it was worth bringing it to this group. If you take all the hospitals in the U.S. and add up their emissions, they would rank on a scale of nations, countries, as the 13th largest carbon emitter in the world, on par with Great Britain. So in other words, the hospitals in the United States probably should have been their own country at the Paris Climate Agreement. I mean, that's how big we are and the impact that we have with our 24/7 operations and everything we have, and try to deal with in these sterile environments and the disposable way that we do practice health in this country. Also, to give you a little bit of a perspective of where we are in the state in terms of our recycling rates. These are the Great Lakes states, and as you can see, Michigan, our recycling rate in the state of Michigan is about 15%. And I would also add that because of our low tipping fee, we're probably one of the largest importers of garbage in the Great Lakes region, simply because of what we have. And we are the heart of the Great Lakes. We touch all of them practically. And so I think to look at those two components and see we have a lot of work to do. So why else are we as Henry Ford Health System taking on sustainability? In addition to the environmental imperative of where we are, the important thing is we're also required by law to really look at this and to conduct a community health needs assessment every year. And we are more and more being required to impact the health of the populations that we serve. And, as folks before mentioned, we could do all the wonderful work in the world right here within the four walls of Henry Ford Health System. But if at the end of the day we send them back to the same unhealthy environments from which they came, where do you think they will wind up again? And so if we really want to move the needle on impacting health, we really need to look outside the walls of the hospital and what we're doing to impact the physical environment, as well as through our own emissions and the things that we generate, but also how do we work within the communities to try to improve the health in those communities. We could say, physician can come in, you need to have, eat better and get more exercise. But if you don't have access to that, how are you going to improve your health? Another reason is our employees are demanding it. We have some recycling here at the system, but as you can see, this picture was not taken that long ago, and we have folks that say, hey, we want to recycle, we want to do things, and we're going to pile all these boxes up and put cardboard in where it doesn't belong because we want it to recycle. So our employees are demanding that we do more, and more as minds change, people are demanding more that we do more on the recycling. We have people, there's a desire to bike to work. We participate in Bike to Work Day every year, and we set up bike racks and some extra bike racks, and they become full. And patients are riding their bikes, and employees are riding their bikes to work. And if we don't have bike racks, they'll lock them right to the front gates of the health system and be right there and they will make their own way and utilize this. So we need to be responding to that and responding to the demand that folks have. And again, if we don't do anything, people will take the matters into their own hands. I mean, these are pictures of people doing their own recycling, and I see all the time people walking out of the door, with boxes of recycling in their hand because they think that we're not, recycling, which we do, but it's a perception, it's an education problem, and that's something that I need to address. And then, then they end up doing their own advocacy. These are posters that I've seen, put up in our corporate offices that I did not put there. But yes, plastic straws do suck, but it is something that we need to work on in responding to the employees. Not only that, we have to follow and pay attention to the trends in healthcare. Costs are continuing to rise in healthcare. We're almost at 20% of GDP in terms of the amount that we're spending on healthcare. We can't continue, there's going to be cuts that are going to be coming, and we're going to have to find ways to save money. We're going to have bundled payments, there's going to be more care coordination, and there's obviously the recognition that the social determinants of health are really impacting this. But government's not going to give us a whole lot more money, and payers certainly are not looking to pay us more money. So if we need to find more money, we need to find that within, and there's a lot of savings to be had. This is not just about environmental economics. I don't believe that you can just do environment and not pay attention to business. They're not mutually exclusive. You can preserve the environment, and you can make good business decisions that are going to impact your bottom line at the same time. So again, going back to the 80-20 rule, if 20% of your health is determined by what's happening within healthcare, 80% of your health is determined outside of that. So that's where the sustainability comes in, and how do we impact that 80% in terms of making the healthy choice the easy choice, and also making sure that the air that people are breathing and the quality of the water that they're drinking is healthy, and that we're taking care of those things. And we've also learned that programs are not as impactful as places. Again, you can do a lot of programming and maybe you touch 1,000 people. But has anybody been out to the Riverwalk on a nice Saturday afternoon and seen how many people are out there? Or go down the DeQuinder Cut, how many people are out there? Thousands, millions of people every year are utilizing those spaces, and yet, they're just a fraction of what we have. So if we build more spaces like that, people are going to utilize them, and so we can really touch a lot more people by building those communities, building more active and engaged communities. So, that's one of the imperatives that we're doing, and, that's why we're all moving towards a triple bottom line, not just us, my partners, my colleagues across the state at Spectrum Health. I'm asked to borrow this slide because it says exactly what I look at, which is, improving the health of our communities through the triple bottom line of putting people first, protecting the planet, but protecting the prosperity of the organization. Again, no money, no mission. If you don't have the money and the funds coming in, you're not going to be able to do the work that we really need to do. So we've really gone on, and in the 4 months that I've been on the job, I've had to look at kind of the model of where we're going, and we're really basing a lot of what we're doing on the Healthier Hospitals Initiative, which was born out of the Practice Green Health and the Healthcare Without Harm movement. So we're really looking across the entire system at all of these areas, engaged leadership, looking at waste, safer chemicals, the chemicals that we use within our buildings, in our furniture, those have a lot of impact on our health. Healthy foods, what we're putting into our body. Greening of the operating room, they're one of the biggest sources of waste and the air handling that we need in order to run the operations. Environmentally preferred purchasing, leaner energy, less water. How do we green building, and then the impact from on climate change with regard to CO2 emissions and transportation. So as I mentioned, this is the elephant that we're trying to tackle and eat right now and consume. It's a big, broad area, but there's a lot of opportunity. We've done a number of sustainability efforts thus far. On the energy side, we have gone through a lot of our facilities. We're working on LED lighting. We're involved right now in air handling and control system operations. I know not the sexy stuff, but that redesign and that investment in our HVAC units and really optimizing those in the building controls are going to save us roughly $2 million a year in energy savings. And that equals the amount of taking about 4,643 cars per year off the roads in 1 year. So that's a big savings, and we're going to be looking at other opportunities throughout the system to save energy. In our OR, we're looking at single-use device reprocessing and recycling so that we're not throwing away devices that can be reused and reprocessed and repurposed. We've gone from having disposable sharps containers, which used to get melted down and then thrown into the trash after they've been grinding, to reusable sharps containers that get dumped and reused, so we're not, getting rid of that waste and adding more contamination to the environment. We just renegotiated our entire waste management contract with Waste Management with a goal of moving us to the industry standard or the current industry average of about 25% of recycling within 3 years. Some of our hospitals are further along than that, but some of them aren't, and I would say the biggest challenge that we have is logistics, just looking at the facility and trying to get different things to different places. But it is the goal to continue to move us there and improve our recycling rates. And we've been doing things, with our food, looking at antibiotic-free poultry, no antibiotic ever poultry, to make sure that we're not, adding to the problems with infectious diseases and antibiotic resistance, et cetera. We've also been involved in active transportation, and we were a sponsor of the Q line in one of the stations there. Tom Habits has been working with a lot of folks on bike paths. We've been a title sponsor of Mogo Bike Share, which has been wildly successful beyond their imagination of what they had originally thought. So they're already expanding that program. And we're putting in paths and walking paths within our facilities and around our communities to give people an opportunity to get out and exercise, and our employees as well. One of my successes in the 4 months that I've been here is I have been able to develop a HFHS Green Fund. So for those of you who are employees and have not given to your employee giving campaign, here's your opportunity to make a difference. With the HFHS Green Fund, we also accept philanthropic donations through that fund to help us spark and support our environmental sustainability efforts. Sometimes it's just getting that little bit of funding, to get the project moving, and so we'll be looking at that. And a lot of the programs we're going to be doing are focusing on employees and impacting those. And the reason why we're doing it, we're working on this for our future. Indulge me, these are my children, my 2 tree huggers. Tyler on the left, who's just started kindergarten, was at his preschool graduation, and they asked him, "What's your name and what do you want to be when you grow up?" And he was the first kid up, and he said, "I want to be a marine scientist." And so I said, well, I want to make sure I have marine mammals for you to study when you get older, so you can do that. And Henry, who always asked me, "Daddy, what did you do today?" And I start telling him about the meetings that I went to. He says, "Meetings, meetings, meetings. How come all you do is meetings? You're not going to improve the environment if you're going to do meetings all day long." So these two keep me honest and keep me doing the work that I do. So with that, I just wanted to do sort of a wrap-up of the day and to say thank you to the Global Health Initiative for putting together this important and timely program on resilient cities. Together, we've seen, and I say timely because, in the past couple of years, for 2 years, we've seen multiple hurricanes that have, hit with devastating effect right here in the United States, and that have had significant impact on all spectrums of the population, the wealthy as well as the more vulnerable communities. And so, but here in Michigan, we're not immune to the impacts of pollution on the health and as well as, on the impacts of climate change here, just with regard to our own climate and the storms and things like that we're getting. So this is a very important topic and why we need to be resilient. So thank you to Amy, who talked about the Henry Ford Allegiance desire to be a health improvement organization rather than a health maintenance organization, and how we need to look at the true health determinants and align our resources in community organizations around common community health goals, and to identify those unmet needs that impact people's access to health care, to health care. And I think the community living room is a fantastic idea. With access to those community supports, that really helps with folks' behavioral health and their social isolation and being able to connect them in a way to, in an approachable way to the resources that they really need. Dr. Cardenas and Guy Williams showed us the similar problems that cities across the world face with regard to poor air quality and the fact that air pollution really knows no boundaries. I was struck by the impact that the education and initiatives such as the app, the air quality app, really have had in Mexico because of their dynamics with the individual cars. But that we're still at the mercy of our climate and the weather and the conditions around us to determine, the air quality. And so we need to continue to be working on the climate, because if the wind's not blowing, or if the sun's getting too hot, we're going to see exacerbations in a lot of our air quality. So Guy Williams said we need new rules if we want different results in different conditions, and that poor air quality has real health consequences right here in the area where we sit, in this zip code. So that really hit home to me. But there are concrete things that we could do to make improvements, but it involves educating policymakers and getting out to vote for positive change makers. So again, I will reemphasize, as former government affairs person, get out to vote. It's an important thing that we all need to be doing if we want to see change in here. And then Dr. Marcolini, thank you for introducing us to NSO. And all the great work you all are doing with street medicine and the permanent supportive housing. As a proud NSO board member, I really appreciate all the work that you guys are doing. And Dr. Bunyabaka told us, if you don't have a house, you don't exist. I mean, that's, in the mind of the government, they say that you don't exist. So that home is really, very important. And that the people's approach of starting where they are and making people the key subjects of making change is important, and to get that participatory planning from the communities. Because if you think that people can't design their own improvements to meet their own needs, we saw here that they're clearly wrong, because people do have the power to be able to do that and build their own change. And that using the housing construction process to learn how to work together really helps empower those communities. And the importance of having community development funds that are directed by the actual community to determine what's needed, rather than the government necessarily coming down and telling them what they need, certainly is empowering and is obviously making a difference. And the fact that you saw loans being paid back at a 97.5% rate really hit home in terms of once you give people that power, that they really have a desire. And Dr. Fowler, Reverend Fowler's story about the residents wanting to pay back their rent, and not wanting to lose their house, really shows the commitment when you give somebody the opportunity. And then lastly, Reverend Fowler, the building the walkable tiny house community that gives people dignity and an opportunity to build wealth and connect with their community is so powerful in terms of trying to move the needle. And doing it for the people that need it the most, the homeless, the incarcerated, the seniors, and the kids aging out of the foster care is just important. And to have that diversity of people all together in that community is important. And so, as you're building and as we're looking at doing redevelopment, doing soil assessments and making sure that as we're building, we're doing environmentally friendly things, with our building is going to impact the long-term health of the communities that we serve. But finally, the fact that there are more good people out there than bad people when you show them the opportunities, I think is the way that I really wanted to leave this and to say thank you all for being good people and for coming here today for this important talk. So thank you for that. So now we will be heading to our luncheon and poster sessions, which will be held directly outside here in the atrium. The lunch session lasts from now until about 1:30. And the poster session then takes place from 1:30 to 2:30 p.m. And we ask that all poster presenters stay at their posts during that time so that you can interact with the folks. We realize there is limited seating for lunch in the atrium, so we ask those sitting down to enjoy lunch comfortably. But when finished, please allow others to sit and eat. You may also return into here to eat your lunch if you'd like and sit down. Please remember to vote. Not just in November on election day, but vote for your top 3 choices of the poster presentations. And again, the voting will close at 2 p.m. and the winners will be announced via email after the symposium. The voting website is available on the inside back cover of your program book. We ask that everyone please also take a moment to fill out the paper evaluation you received. Your feedback is very valuable to us and those planning. For those of you claiming CME credit, you will receive an email within 10 days with instructions. And lastly, on behalf of Henry Ford Health System, we would like to thank all sponsors and supporters of the Fifth Annual Symposium. We appreciate your generosity that enabled us to put this important event together. At this time, we would like to thank all those speakers, especially those who traveled far to be with us today. Please join me in giving them all a big round of applause, and thank you. Now go forth to lunch and enjoy. Thanks.